Bore da, good morning. Croeso, welcome to today's meeting of Powys Teaching Health Board. This meeting is being recorded. We don't have a live streaming facility today, but it will be available on the website very soon. I'm Vivian Harpwood, Chair of Powys Teaching Health Board, and provided on the screen you will see details of the independent members, the executive members, and any additional attendees who are present today. There'll be no apologies for absence received for today's meeting. However, I would very much like to welcome some people who are present and present for the first time. Kathy Poynton, delighted to welcome you as our new independent member. And also David Collington, newly elected chair of the Community Health Council, who's observing along with Katie Blackburn today. So welcome to both of you. Thank you. Are there any declarations of interest, please? No? Fine. Can we turn to the minutes of the last meeting? That was held on 29th of September. Could I ask you, please, to let me know if you have spotted any matters of inaccuracy. I'm not going to do it page by page because there are 22 pages. So if anyone has spotted anything, would you please put up your hand and we'll go directly to it. Well, that's encouraging. That means that there was some very good minute taking. So well done. Thank you for that. Could we turn to any matters arising that are not on the action log or the agenda? No? All right, thank you very much. So can we approve those as an accurate record of that meeting? I can't see any dissenting hands, so we'll assume that we can. Thank you very much. I want to refer now then to a chair's action on the 12th of November, which is here for ratification. It was an urgent chair's action that we had to deal with. Ronnie, do you want to just speak to this quickly?
Thanks, Chair. Just to say, Chair's action was taken in line with standing orders, and the detail is included within the paper, excluding the commercially sensitive information, and Hayley will be able to pick up any specific questions. However, the decision was taken to approve the proposal.
Right, so thank you. That's just for ratification then, and just for formality, so that it is properly recorded. Thank you very much. And the action log, Rani, glad to say, very short action log and looking good.
Yeah, just one action outstanding, which has been transferred to the Delivery and Performance Committee, who will receive a planned care update report at the December meeting, and following that the action will be closed.
Right, thank you. So just to carry on then with the next agenda item, an update from me as chair. Well, as chair of the board, I'm very sad to be saying goodbye today to Melanie Davies. It's her last board meeting as our vice chair. She's been absolutely fantastic, very, very supportive vice chair, and she's worked very, very hard in her role on her portfolio. Also, saying goodbye to Rani Mallison, our board secretary. I never thought that the day would come when they'd both be going at the same time. However, congratulations on your new role in Aneurin Bevan, and we wish you all good luck on that. So it's a sad day, but also a happy day, because I'm sure Mel is going to go off to do great things as well. And we'll be watching out for you and what they're doing in Aneurin Bevan, Rani, in due course. So just news from me. We have advertised the vice chair's post. I'm sorry to talk about this. It's a bit like Hamlet, isn't it? You know, the baked meats are barely eaten, and we're talking about the next person to come in. But sorry, Mel. But anyway, we have done a sift, and we will be interviewing some very promising applicants for that post. Then as far as anything else goes, as far as my own work during the month, it's been 2 months. It's been extremely hectic, but there have been some highlights. Unfortunately, for technology reasons, I was locked out of the Nurse of the Year event, which is always lovely. So I didn't actually make it there, but I just have to say that, you know, I enjoyed doing the selection process on behalf of Powys, because we do always sponsor the adult nurse section. So I don't think there's anything else I need to take up your time with. I'll hand you over to Melanie now.
Thank you, Chair, much appreciated. So I'll just mention a few things I've been up to and then make a little comment if you'll indulge me. So I've been doing the normal National Psychological Therapies group, and we've been doing an interesting piece on waiting times and how that impacts corporate parenting group, and obviously the chairs and vice chairs. I attended the joint partnership on your behalf, Chair, and they were forwarding the National Park Plan, which was very interesting. Director of Nursing interviews was this week, and we had a successful applicant. I'm not sure if they'd agreed to that post, but that was very positive. And we've got the Children Commissioner coming to the Regional Partnership Board next week, which is a very interesting for people to know if they want to watch that. Next week, I've got a ministers' meeting. I'll be going to the Safeguarding Board as usual, and we've got the Quality and Safety of Wales group coming up just to finish off my month. So yeah, I'm going out in a happily busy as ever manner. I just really quickly say thank you to all of you. Thank you for working with me. It's been an absolute pleasure. I was very lucky to get the post. I've been very, very humbled, and the last 2 years have been particularly pertinent. So I just pay homage to all the people that work in Powys Teaching Health Board, right the way from the board all the way through. It's an amazing place to be and have the privilege of contributing to. So that's my thanks to all of you, and yeah, just keep at it and keep going, getting in there. That's my my view. So I'll be quiet now because we're in a full board meeting. So thank you very much, each and every one of you. Okay, thank you. Unless you've got questions about what I've been doing. Sorry, back to business.
All right, thank you, Mel. Shall I ask Carol then to come in with her report, which will outline, cover actually some of the things I've been doing too. So Carol, over to you.
Yes, thanks very much. Good morning, everyone. My apologies for the delay in getting my report out. I hope that it's been informative. However, a couple of things I did want to draw attention to. In particular, really, the challenges, and just pick up from where Mel is, really, the last 2 years have been phenomenal, really, in all of our lives and in all aspects. And to be really clear, the pressure that the NHS and care system is under is still significant. So the pandemic is not yet over, and you'll see from my report that I draw attention to the test, trace, protect and the vaccination programme, both of which those functions are working absolutely flat out at this stage. We have high case rates of COVID-19 circulating in our communities still, and the test, trace and protect service has been expanded to try to support that effort. In terms of vaccination, again, a highlight brought out in the report really about how the programme continues to perform well. But additional elements are being added in to this programme at a frequent pace, and so the adaptability and flexibility of the teams that are working in here is hugely significant. And you will have noted from my report that some of the changes that have been brought in will continue now to be incorporated into the offer we make to the public, and in particular that's boosters to people who are 40 years and over, and second doses for young people aged 16 and 17. Importantly, and for any members of the public who do watch this board meeting, an important change that if you're under 18 and you have had a COVID infection, a second dose would be after 12 weeks. So hopefully that's helpful. A lot of flexibility needing to be shown because of the to the 3 vaccination centres, I make a reference in terms of risks to that, in terms of venues, but I know the team is working very hard on that. Out of the 3 mass vaccine centres, only 1 is on Health Board premises, and so agreements with others are being further discussed. And the workforce challenges, which we have put plans in place to try to reduce the risk of not having sufficient staff. I wanted to touch on urgent and emergency care, the elements of strain that the system is under. We'll touch on that in a more substantive paper shortly, so I'll come back to that. And then just to highlight that in planned care, good progress is being made by the provider part of our organisation in reducing the waiting times and the backlog of people who are waiting on a waiting list. Some rather mixed fortunes in terms of access to secondary care services, but a huge amount of work going on there. And then just finally, I think the chair mentioned the Nurse of the Year Awards. I didn't put that in my report, but that was a really lovely event. But I would like to just pull your attention to a couple of other key events. We held a showcase event with staff from across Test, Trace, Protect and COVID-19 vaccination service. I know a number of board members were able to make that event. Extremely positive and really did demonstrate, in my view, the partnership working. So we had colleagues from Powys County Council and from the Health Board participate in that. And then finally, on this part, Dyfed-Powys Police last Thursday extended an invitation to us to join their police awards. And it was extremely moving to be able to receive the Chief Constable's Award for Outstanding Achievement on behalf of the NHS here in Powys and for my colleague Steve Moore in Hywel Dda. For one public service to formally recognise the efforts of another really does make this very special, and so important to share that across all of the NHS here in Powys. And then finally, I would just wish to reiterate the Chair's recognition and thanks of both Mel Davis and Rani Mallison, both of whom have been extremely valued colleagues. And we wish you well for your future adventures, and thank you for your wise words, pragmatism and support that you've shown to me personally over the time. So thank you very much. Thank you, Chair.
Thank you, Carol. And you mentioned the one vaccination centre that's on Health Board premises. I was absolutely delighted to get a flu jab in Basil Webb, which was unrecognisable. Wonderful, wonderful improvement to that building and a fantastic place for people to learn. So I had a sneak peek before the official opening. Wonderful. Even though I had to endure a flu jab, which of course I was delighted to have. So thank you. Right, shall we continue then, please, with section 2 of the agenda. Agenda item 2.1. I think maybe Carol, you want to start, and then Hayley might take over from you, unless Hayley wants to go straight into it.
I'll just do a couple of words of introduction, if I may, Chair, to thank, first of all, the planning team and teams right the way across the organisation in preparing for the future, really. We've talked about the pressure of the here and now. It is significant, but it's our duty to also prepare our organisation and prepare our plans for the future, starting from April 2022 on that 3-year basis to at the end of 2025. So I just wanted to thank colleagues for arranging to bring this item forward, and I wasn't going to say any more than that, and to hand over to Hayley. Thanks very much, Hayley.
Diolch. Dwi'n falch iawn I gyflwyno y fframwaith cynllunio a'r blaenoriaethau strategol ar gyfer y 3 blynedd nesaf i'r bwrdd drafod a cymeradwyo heddiw. Yeah, thank you. This paper sets out the Health Board's planning framework and our emerging 3-year strategic priorities as we're undertaking the work currently as an organisation to develop, in line with Welsh Government requirements, a return to our 3-year planning IMTP integrated medium-term plan submission to Welsh Government by February next year. We are in the thick of it currently in terms of pulling this work together, and we have this paper sets out the recently published planning framework guidance from Welsh Government, which sets out clearly the ask in terms of the expectations for all health boards to submit our IMTPs by February, and also the relevant content that Welsh Government is seeking to include, for us to include in it, as well as an important section on the new programme for government and the ministerial priorities that we need to meet. The work of the team, obviously context is important at the moment, and there's a huge amount of operational system resilience pressures across the organisation. So the planning team have been working closely with colleagues to set out as stripped back a process as we possibly can, but actually that does engage the wider organisation to help drive the content and the priorities set within our plan over the next 3 years. We have particularly been working closely internally to develop the planning framework, which is attached for the board today, but also some really practical guides and support for members of the organisation around how to support the directorates to deliver the content and to consider both the context and the position, the current position, and what the priorities should be going forward. And the outputs of that work, we're currently at the stage now of considering that and working to develop a draft IMTP by mid-December. Just wanted to say that the partnership landscape for us is quite complex in terms of delivering our integrated medium-term plan, and the paper also sets out the work that we're doing in partnership to look at alignment across the content of a plan around within our existing relationships and partnerships within Powys, things like the Regional Partnership Board, the Public Services Board, but also importantly the expectation for us to reflect strongly in our plans, our joint working and regional partnership working across both NHS Wales and cross-border into England. So again, there's quite a lot of work we're undertaking currently, meeting with respective organisations to make sure that we have that content tied in as well. The last part of the paper then sets out the strategic priorities, and I think the key issue to reinforce here is we're going back to the framework that we set within a healthy caring Powys, and a return to that framework in our 3-year plan, and the priorities and the structure of the IMTP I hope board members will find familiar. But I wanted to just signal that we will be undertaking next year a review of our progress against our 10-year strategy, so that will form part of future iterations of our IMTP updates on an annual basis. And on page 12, just at a high level currently, the sort of strategic priorities that are coming through strongly that you will see in the content of the plan. Clearly, this is about integrating our service, finance, workforce and operational planning together coherently into this plan, and it's an extremely busy time, but we are planning to bring it back to the board in its January meeting for consideration as a draft. And at this point in time, we hope to be on track to deliver that. We do understand from the recent NHS planning framework guidance that's been published by Welsh Government that usually we have the financial allocation information just before Christmas, sometimes at Christmas Eve. It looks like that might be in the first week of January when we receive that information for this iteration. So other than that, that was a quick introduction to the paper, Chair. Happy to take any questions.
Thank you, Henry. Obviously, this is an ongoing project. Sorry, there's a bit of an echo on the line. It's very important, you know, that we recognise that strategically this is crucial to the Health Board, and that actually some things have changed since the last full IMTP. For example, the socio-economic duty is now with us, has landed, and so on. So it's clearly something which is moving and living and breathing, as it were. Are there any questions, please? I can see Ian's hand up, and then Trish.
Yes, thanks, Chair. Just three comments for me. First of all, thanks for the paper and the planning framework. I thought it was really clear and well laid out, and recognising the fact that you've had particularly challenging timescales and it's not an unpressurised environment. So my congratulations to the team for doing that. Just 3 points really. Noting the fact that it's the next IMTP will be year 6 to 8 of our health and care strategy, and I think the point for me that really came across in the set of papers today was the fact that it is really good to see the huge amount of work that's going on, which is laid out in the papers today, on the innovation and modernisation that take us to some of the goals. So the seamlessness, that golden thread, I think that was really good to see across the papers. Two other comments. In terms on page 8, as far as the SWOT is concerned, it seemed to me that a significant and fundamental challenge for us as a board is the digital infrastructure and the lack of a integrated contemporaneous clinical record. I would see as both significant and fundamental challenges. And my final comment is just an ask for a briefing, if you like, outside of the meeting from staff engagement and getting that team-based view, which is really, really good. I'd be very interested to find out a little more about how that was accomplished from the perspective of my role as chair of the Workforce and Culture Committee. So perhaps we could arrange to do that separately, Hayley. Thank you very much.
Thank you, Ian, for those comments. Thank you for the contribution around the SWOT. We'll obviously take that into account, and obviously as part of your assurance when we bring it back to January, we usually translate this into this is what we've done in relation to both partnership, alignment discussions with neighbouring health boards, but also on the staff engagement aspect as well. But happy to have additional conversations with you as chair of that committee as well to give you assurance on that. Thank you.
Thank you. Trish?
Thank you. Firstly, I'd like to thank you and echo Ian's comments about the document. It is really helpful and scopes the challenge that we've got going forward, but I think it's a really useful document. What I wanted to highlight, I know and understand that it's a planning document, and it's the scope of it, but in order to understand whether or not we're achieving our plans, we do need to be looking at milestones as we go forward, and we also need to look at outcomes and performance indicators. I note in the our performance report, which we'll consider later on, that there are changes that Welsh Government are requiring, and I just think it's important that we hold on to some of the measures that will help us understand whether or not we're on track to achieve what we're planning to achieve.
Yeah, thank you, Trish. Just on that point, there is an expectation from Welsh Government every year. We describe the first year of each of our IMTP in the annual planning space around the key milestones and deliverables we're expecting to deliver. And that's what you'll see. We did it last year. That's what the report is later, around our progress on Q2 against the deliverables that we set this year. Completely agree. And there's an expectation from Welsh Government that we have that outlined for year 1 and indicative for year 2 and 3 in terms of the IMTP. And in terms of the outcomes and performance indicators, they're really important points, and you know, we'll hopefully be able to see as we track this back then, our progress reporting. We are also at the moment reviewing our integrated, improving performance framework as well, just to make sure that you can see where are we against progress against the plan as well. So really important points, Trish, particularly the issue around outcomes. There's quite a focus sometimes on process rather than the outcomes we're trying to achieve. So that will be something we will try and reflect in our reporting that comes through to committee and board.
Thank you, Hayley.
Thank you, Trish. That was a good point. Ian, is that a legacy hand, or did you want to come back in? Oh, okay.
Legacy, sorry.
Legacy. All right, that's fine. A new terms, actually, that's arrived ever since we've been doing these virtual meetings, isn't it? Anyway, thank you. We've had some discussion. Are we ready to approve this planning framework and draft strategic priorities? Yes, thank you. Thank you very much, everyone. That's excellent.
Thank you.
So we turn now to the next item on the agenda, which is radiology informatics system procurement programme. This is really interesting, I think. So I think Claire's going to lead on this.
Yes, thank you, Chair. So this paper is the risk programme outline business case, and the purpose of the paper is to provide the board with a briefing on the programme outline business case for radiology informatics system procurement, which is colloquially known as the risk programme. And it's just highlighting the current situation and benefits of the risk for Powys Teaching Health Board patients, and also highlights any associated risks around this programme at the moment. The programme team did attend the executive meeting, including their finance lead, to assure us that this is the best way forward, as it's a very technical paper, as you can see. And our head of radiography is involved very closely in this work and is supportive of this way forward, just to reassure the board. This piece of work is time critical because the current system that's used, which is called PACS, the Patient Archiving Communications System, is due to end its tenure in 2024. So we have to start working now to put something in place. The current system does have limitations, and the new system does aim to have better connectivity across all hospitals in Wales, allowing us to work much more closely, which is really important for Powys when we commission services. But it's also going to look to have better connectivity with our English counterparts, which is also important for our commissioning system that we use, because we use a lot of diagnostics in England as well as Wales. So I won't go into any more detail, but I'm very happy to answer any questions.
Thank you. It's really important for our patients, this, isn't it? So does anyone have any questions? Those of us who can understand all the technical issues. Ian?
Yeah, thanks again, Chair. Just a couple of points from me in terms of feeding into the ongoing assurance process around this. I think there are a couple of issues for me, one of which you just mentioned, Claire. I think we need to be assured that there aren't any issues for Powys patients on 2 points. One, around the phasing of the implementation. So we'll in parallel have the old system and the new systems, and there aren't any issues for us in Powys because we're going to be spanning both of those camps at the same time, and the connectivity with England as well. A really important point I think that you mentioned, that's built into the spec from day one with us, and not an additional one. The third one, and I have been sad enough to read the long paper as well, Claire, is I wasn't clear from this documentation. They ruled out as part of the overall scoring in the 5-case model the in-house, and there wasn't, not that I'm saying that that's a good thing, I'm just conscious of the fact that we have a number of systems that are commercially supplied that perhaps their implementation hasn't been as seamless as we might have expected. And I'm also conscious of the fact in recent history that we've been very successful in NHS Wales, particularly around COVID, test and trace and the vaccination, which have been in-house examples of that. So I had some just minor concerns around the fact that that wasn't being considered, bearing in mind our recent experiences.
Thank you. I think Carol wants to come in first on that one.
Yes, of course, yeah.
Yes, thanks very much, Ian, for raising that. It gives me an opportunity to also add to the presentation of the paper that at the collaborative executive, which is where the individual health boards and trusts come together and work together on developments, we had that very conversation, Ian, about the, without wanting to sort of preempt or make a general rule of thumb, but the sense that we should always try to ensure that we've got a very open mind about supplier, which might also mean that we make it ourselves in Wales. I think there was quite a lot of discussion and robust discussion about that. And so I just wanted to add that that very issue has been discussed about a make or buy. There is, of course, significant expertise required when we are making, and whilst the pandemic was, it's the most unique circumstance, and we have achieved a lot. I think there is some nervousness that if we made everything, and this is one business case, and there are many other quite significant digital business cases, our ability to be able to bring these developments through in a timely way may well be challenged. So I think there's a bit about being really quite selective about which ones would Wales wish to make themselves rather than buy from a market. But just to assure you that that discussion has taken place most robustly.
Thank you very much, Carl. That's really helpful.
And just to add, Ian, we did see quite a lot of reassurance that the systems would work within England and across borders as well. Yeah. And we've certainly asked a lot of questions around that.
Great,
yeah,
thank
that's
you.
always been a bit of an issue, hasn't it, for us?
Yeah, it's currently an issue, so we hope it'll be an improvement.
Ronnie, you were next.
Thank you. Claire, I thought this was a very helpful paper, and I tried to go through the detail of all of it.
Yes.
But of course, the provision of this service is hugely dependent on the resource, the staff that are available to actually effectively administer it. So I just wondered, how confident can you be that the provision of such staff will be in place, because there is a national shortage? Thank you.
Yeah, I think we've got two issues here. I think there's the technological issue that we've got, which we need the software and the hardware to actually meet our demands, regardless of our staffing issue. But we are very aware of the challenges that we've got with radiologists, particularly, but also radiographers nationally across the whole of the UK. And we are looking at other models. So we're looking at reporting radiographers. So we're looking at extended the scope of radiography to take on some of the more simple reporting on the tests that are done. And I think there's quite a lot of work looking at AI now, looking at artificial intelligence, and our limitation will be not having the tech to allow us to do that. So this puts us in a really good place where we will be able to adopt new technologies as they come in if we can modernise our system as best as possible. There's a national piece of work looking at recruitment and training of all health professionals, and we do recognise radiography and radiology are a big challenge. And there's also look at international work, because the other good thing, if you've got really tech systems, is you can have reporting done anywhere in the world, frankly. So if we've got good connectivity and good technology, we can be more creative in the ways that we work.
Thank you.
Thank you. Trish, you were next.
Okay, thank you for the paper. I also spent a very long time reading it, but perhaps, or both papers, but perhaps with less success. I'm really pleased to know that there should be no cross-border issues, but I'd like to be reassured on that as the project progresses. I did note I wondered what assurance are we having on information governance and cyber security? And thirdly, I didn't quite understand whether or not there was a financial risk, what the current contribution is and what future contributions we would be required to make as this goes forward.
Okay, well, with regard to the cybersecurity, there's a very big scrutiny over anything we do across Wales and across borders around ensuring that we're GDPR compliant, and there is that membership in the team that are working on the programme, so we are taking assurance that that's being taken very seriously. With regard to finances, they're not exactly clear at the moment what they will be, but we did have the finance lead at the execs meeting, and they have spoken to Pete, and Pete is assured that we're in as good a position as we can be at the moment. Of course, this is only a precursor paper. There will be a proper business case that comes next, and then we will have much more detail the next time. So that is a slight risk at the moment, Trish, that we're not exactly cited on the finances. It may change the way in which we pay for how we get these services, because we procure most of this work, as you know, but Pete was assured by the finance lead from the project that everything was in order, and we have as much knowledge as we can have at the moment. I don't know if Pete wants to add anything.
Yeah, happy to come in. So as it's an outline business case at the moment, we've got indicative financial figures. Those figures, as Claire alluded to, are made up of both capital and revenue. They're included in the paper. There's a highlighted capital requirement of 20.6 million and a revenue requirement of 1.2 million. That will be to establish, install the new system. In terms of ongoing costs, the current baseline recurrent cost of the current system is circa 6.8 million, with a forecast potential recurrent cost of 7.3 million nationally. So that gives a potential gap of 500,000–600,000. There are other details to be worked through as part of the full business case, which may close this gap, and there are some opportunities that have been identified. If it does remain to be a gap, we may have a share of that, but on a percentage population basis, you're talking around 20 to 30,000, so it's not a material sum against the benefits and all the other issues that have been outlined. And as Claire said, we currently receive our services via SLA and other arrangements with other organisations, so that would all be included in those sort of funding flows arrangements. So minimal financial risk based on what we know at the moment.
Thank you very much.
Thank you, Pete. That is reassuring. Francis, you're next.
Thank you, Claire. No, I'm 100% behind you in general, and I think this is very good. The one thing that always with interconnectivity and stuff being outsourced anywhere is, where do the legal liabilities lie when misreporting occurs? Because as we all know, radiology is an area where there is a certain amount of litigation around it. I'm just interested to know what the governance processes are likely to be or looked at.
To be honest, Francis, I don't think we've got to the stage where we've looked at seriously looked at the opportunity of reporting elsewhere. It does happen in the private sector, as you know, quite widely already, but we're not at that stage yet. But you're absolutely right, there needs to be really clear governance around who owns the case, who owns the reporting, and very stringent quality control around reporting. So I think when and if that piece of work is done, you're absolutely right, that will have to be very carefully done with regard to the governance around it.
Thank you very much.
Francis, if it's any help, the litigation in connection with, for example, cervical screening has been directed at the person responsible for doing the screening itself, you know, the actual whoever it is who's analysing. So that's the issue normally. But well, thank you for that. A very, very carefully worded paper, very well put together, and the executive committee has considered the outline business case already and is supportive. Yeah. So we're being asked as a board now to approve the outline business case set out in Appendix A. Is everyone happy to do that? Thank you. And the programme team as well. We're being asked to approve the programme team proceeding to procurement of the preferred solution and the development of a full business case. Is everybody happy? Any dissenters, please indicate now. Okay, thank you. So that's approved. Thank you very much.
Thank you very much, Chair. And
now we can go on to ask Alison to present the next item 2.4 on the agenda.
Diolch, Chair. Boards are everyone. Thank you very much indeed. So my paper relates to the South Powys programme, consultant-led maternity and neonatal care. And the purpose of the paper today is to provide an update to board in relation to the outputs of the maternity and neonatal work stream, and to highlight really the need for further consideration about the date for the planned strategic change in the pathway for consultant-led maternity and neonatal care later this financial year into Q4. So the paper today is to ask board to ratify this decision, the one to maintain current pathways, and to note that this will be reviewed later this year.
Thank you, Alison. I can see I've omitted agenda item 2.3, so we come back to agenda item 2.3 and carry on with this now, if that's all right with everybody.
Thank you, Chair. Yes. Colleagues, just to touch on the background, and colleagues within Patient Experience, Quality and Safety Committee will be very well cited on this agenda, which is reported regularly through a variety of papers there. Colleagues may recall there was an extensive public consultation in 2014 which enabled the provision of the South Wales programme, which identified a 5-site model essentially. And of importance to us is the role of Prince Charles Hospital in Merthyr in relation to emergency care, as well as that for pregnant women and babies in terms of neonatal services. Obviously, women's choice heavily influences decisions in terms of pathways taken, and the opening of the Grange in November 2020, whilst we undertook quite a lot of work and coordinated the approach to that speedier change than planned, we've taken a slightly different view towards maternity and neonatal services, which is incorporated in our phase 2 approach to the strategic change, and that's where the maternity and neonatal work stream essentially has been placed. I think just to note, the COVID-19 pandemic has affected every service, as we know, in Wales and more widely across the UK, and maternity and neonatal services across the board have been impacted upon in similar ways as a background context for this work. We obviously, our population of Powys utilised maternity services in England and Wales, and therefore mentioned in the paper there about the pressures across the border as well. So in relation to the maternity and neonatal work stream, the terms of reference, the scope for that work was agreed in January 2021, and the aim of that work is to inform board's decision about the timing of the strategic pathway change in line with the South Wales programme, and that work was predicated on a readiness assessment and underpinned by robust assurance arrangements and an implementation plan. Colleagues will see as part of the assessment, part of the monitoring of that work has been about ensuring we would be aware of any unplanned pathway change in the meantime, and you can see from the data included in the paper that hasn't happened to date. You'll see reference to the maternity assurance framework in Appendix 1, Chair, and that sets out some of the factors that are taken into account by the work stream in terms of readiness, and also reference in the paper to the internal arrangements and external oversight for Cwmtaf Morgannwg University Health Board in relation to maternity and neonatal services. I'm not proposing to go into detail there, Chair, for this purpose, but I'm quite happy to pick up any questions if need be. You'll notice there have been a couple of ministerial statements in relation to this matter, and the most recent reports published at the beginning of October identify the improvement work that is taking place in terms of neonatal services in Cwmtaf Morgannwg and the improvement work that remains to be undertaken. Please note in the paper we make reference to data and obviously that's featured in our board meeting thus far and will probably do so for many other services as well as maternity and neonates. We're undertaking a local piece of work to enhance the data that's available to us in terms of these services and have identified the need to undertake that nationally as well. The conclusion of the paper, building on its contents, Chair, suggests that the timing of the strategic change be subject to board approval based on the quality, safety and experience of women and families who use the service and based on our findings in terms of readiness. And the proposal is that that decision comes back to board for consideration during Q4.
Okay, thank you, Alison. Melanie, your hand is up.
Thank you, Chair. Just to welcome this report. You know, it's really important that the board is focused on this issue. We're all really aware of some of the areas I think that and the challenges around maternity around all of our borders, and this cautious approach I think is really welcomed and should give our population assurance that we're focused on it, and actually the improvements that have been done around the borders, particularly in the South Wales area, before we make any changes. So it's just a comment that and obviously this will be coming to Patient Experience, Quality and Safety Committee again, and we have regular updates, as you will be well aware. So it's just really to acknowledge the work that's going on and to say that it is really appropriate that we have this focus in this area. Thank you, Chair.
Thank you, Mel. Are there any other questions? We are being asked to ratify the decision to maintain the current pathways in relation to consultant-led maternity and neonatal care, subject to, of course, the review that will take place during Q4. Is everyone happy for the time being then to ratify this decision?
Chair, I noticed that, Chair.
Oh, I'm sorry, Carol. Oh, Katie and Carol. No, it's not Carol, it's Trish. Katie, sorry about that.
That's all right. I just wanted to take this opportunity to thank both Alison and Hayley, who have kept the CHC involved virtually at every meeting and updated us from a Powys patient perspective. So I just wanted to provide that reassurance and thanks.
Okay, thank you. Carol.
Yes, thanks very much. Just subsequent to the paper being written, it's probably useful for the board to know that Welsh Government will be developing a national improvement programme around maternity and neonates. This is in part, at least as a result of ensuring that the learning from experiences, including in Cwmtaf Morgannwg, is spread across all of Wales. Some colleagues will be aware that there is something similar in England as a result of the Ockenden review there. I think from our perspective, our focus on maternity will provide a very useful contribution to that All Wales work. And I did just want to pull up in particular the part of the report that Alison and colleagues have put together about the use of data, and really important to be data driven. To understand where there may be issues and areas for improvement. So we'll be participating in that broader work, and that's being led by the new Chief Nursing Officer for Wales and the Deputy Chief Medical Officer for Wales as well. And to thank Alison for bringing the paper forward.
Yes, thank you, Carol. I know the Welsh Risk Pool is on to all of this as well, trying to get the message out nationally, so it's really important. Trish, you were next.
Yes, thank you. I think Carol's probably picked up on my point, but I was very pleased to see the progress in the data and data collection and analysis. I think that's so important for the small numbers of our population, and particularly when they're going different directions. So I welcome this, and I'm supportive of the proposal.
Good, thank you. So can we ratify that decision then? Thank you very much. Now back to agenda item 2.3. I apologise to Jamie. I'm sorry, Jamie, I didn't mean to leapfrog your item. I just, my eyes sort of strayed down too far on the agenda. So over to you.
Thanks, Chair, and absolutely no apology required at all. You gave me a couple more minutes to check my facts. Thanks, Chair. Thanks, colleagues. This paper is a summary of the full business case, not the word outline business case that we've considered in committee already for commercially sensitive reasons. So I think for the record, colleagues will recall we took a paper to committee in January 2021 about the head lease for this multi-occupant building. Colleagues will also recall this is a model of lease which is in place across new developments in Wales. The attached document within the paper that the board has seen is the full business case and is coming to board for approval before submission to Welsh Government. This is not a capital case, it's a revenue case using a third-party developer as outlined in the paper. We as a board made a commitment to this development in November 17 as part of the national pipeline for such schemes, and as the paper outlines, based on our assessment of the limitations of the current building and the needs for development to serve the population in that North Powys area of Llanfaircyrainian and surrounding area. The submission is therefore not for Welsh Government approval, but a necessary step providing assurance on the scheme and the committed investment by Welsh Government. The case has been developed through the project structure with expert input from both the district valuer but also a shared service partnerships estate. The cover paper, which colleagues have seen, summarises some of the content of the full business case, including the benefits realisation for the population, the size of the scheme and the scope of it. The lease will be 25 years initially, with expectation of further leases subject to the service needs at that time. The lease is a tenant internal repairing lease, so the tenants will be liable for repairs with the exception of the lift, the boiler and external grounds and parts of the building. Pleasingly, colleagues will also note the BREEAM excellent rating, which is very important for the benefits realisation and carbon neutral or carbon net zero, as well as the additional benefits of potential for dental services in that area of Powys. The risks are outlined within the wider paper, although the bulk of the risk will rest with the developer in line with all 3PD third-party development schemes. The FBC lays out the full case for change, economic commercial case and the benefits for the population and the services in that North Powys area. And I'm pleased that in full business in committee that this was approved by the board. Thanks,
yes, thank you. So it has been approved, but you know, the information is there and we're just ratifying it as a matter of record. So is everyone happy? Thank you very much. Now, Julie, next, very important, health and safety policy.
Thank you.
It's in the papers.
Thank you, Viv. Just to say that this is a policy that has been considered at a number of committees and a significant amount of work has been undertaken to ensure that this policy has been updated to reflect the organisational approach for health and safety. I think it's important to note that this policy sets the approach for the organisation and clearly recognises that within the health and safety requirements of the organisation, there are specific areas for which we have director leads across the organisation. For the first time, this policy identifies the expected level of competence and training that managers will be required to have to undertake their role. And it also identifies a risk assessment approach and a risk assessment template to enable and support managers to identify those risks and take action at the levels that they possibly can within their roles and responsibilities. The policy also identifies the new site management arrangements and how they will support the organisation's approach to health and safety. The board is being asked to both consider and approve this document to enable us to then fully implement across the health board. I'll stop there. I'm sure there will be questions.
Thank you, Julie. I was really glad to see, you know, the aim is to promote a positive culture, you know, in terms of health and safety, because it is everybody's business, you know, and we owe a duty of care under the statute to and the regulations to anybody coming onto our premises, visitors, as well as patients, to ensure that all premises are safe. And other legislation as well, of course, the Occupiers Liability Act, but that's another story. So we are being asked actually to approve this this policy Before we do that, Mark, you want to come in?
Thank you, Chair. Yeah, welcome the update in terms of the policy, and I've tried to touch base with Julie on a couple of specific points, but we haven't quite managed it in terms of commitments. There was a point about the statutory compliance, which is on page 11 of the policy, and the issue I've got is the paragraph under statutory compliance, which refers to the compliance sitting outside this policy, and it may be perhaps slightly semantic, but I don't think that that is accurate. It must sit in this policy, albeit that we manage it by a different process.
I think, Mark, that what that statement is saying is that there are very specific policy and statutory compliance issues that we have to address in each of those areas, and the detail on those issues is not included in this policy, or that this policy would become a tome. So this is the overarching approach to the organisation, and then there is a policy framework that sits underneath, and the very specific technical requirements of things like water safety, asbestos, fire safety, etc. are covered in the respective policies that sit within the overall approach to the areas covered within the Health and Safety at Work Act. So that's what it's trying to say. This policy is not trying to cover all those areas, and there are separate policies for each of those areas which are led by the respective directors.
Yeah, no, I understand how we do it in practice. It may just be a semantic, and my reading was just slightly different of it. And I just wanted to make sure that those policies are covered by this policy, because this is the overarching, and the others fall under that.
Absolutely, Mark. I think we are saying the same thing, so maybe we do just need to clarify that in that point. So yes,
great. Thank you.
Ron can help us.
Yeah, no, I think it's about those following elements will be deployed out of this policy.
Yeah.
And so it's within the framework of health and safety deployed through different policies.
Yeah, so we can change that wording slightly, can't we, Ronnie, to reflect that point, Mark, just for clarity. That's really helpful. Thank you.
Thank you. Yeah, I must say I read it as Julie explained it, but for clarity's sake, we may as well, it wouldn't hurt, would it, to just tweak it a bit.
I think that'd be helpful. Yeah.
Thank you, Mark.
Thank you. The other point I had was relating to the role of the Performance and Delivery Committee, which is identified graphically in the flowchart on page 22, and whether there's a disconnect between the flowchart shown on page 24, or am I not understanding how that flow is going to work? Because
I think. Sorry, Mark. No, carry on.
The delivery and performance is shown on page 22, reporting into board, whereas on page 24, it's absent. So I just wondering about that as a disconnect or some reasoning behind it. Thank you.
Yeah, Mark, I take that point, and I recognise when you put that query in yesterday. I think that the page 22 of mine, the Health and Safety Communication Support Structure, shows the overall, and page 24 shows the management performance reporting. So perhaps we can actually change that, or we can add in the committee above the executive team and onto board. If that helps, we can add that box in, Mark.
Yeah, I think it's how we do it in practice as much as the box.
All right.
Is just making sure if we say we do something in a way that we actually do that. So it's for clarity, and also just how we actually review how we actually do it. So thank you.
Yeah, thank you. Yeah, thank you, Mark. Was there anything else? Okay, thank you very much. Ronnie?
Thank you. Julie, I thought it was really helpful to have this policy set out in such clear detail, so thank you for that. I have one general comment and one specific one, and as you know, I have an interest in this area. How this works in practice is, of course, hugely dependent on the process of risk assessment and the need for a systematic process from bottom up. And that in turn means that there needs to be a systematic approach to training for those that are involved in risk assessment. So I'd just like to be assured that the training at various levels is appropriate to the appropriate levels of risk assessment. That's the first point. And the second issue, and this is one that I feel particularly strongly about, having spent some years in enforcement, is the issue of near misses and the importance of having a root cause analysis of near misses, because the difference between a near miss and something serious is only happenstance. So I just like assurance on that point as well, please.
Okay, if I can just take the training, Ronnie. Fantastic, we absolutely are in total agreement, and certainly an approach that the executive team has supported. There has been significant investment in both management time and health and safety time in relation to training for health and safety. And that is why it's recognised in the policy that depending on where the manager sits and the level of expertise and knowledge they require, there are different routes for training. So that is why that is included in the policy document. What we have agreed from a management perspective is that that absolute focus on getting the risk assessment process right has to be a core part of the work programme that takes us forward, and it has been a core part of the work programme for certainly the last 6 months, Ronnie. So that is the thing that really does help change our culture in terms of managers' responsibilities, and that is the thing that we have been supporting and enabling managers to do. And that is the thing that we've done a massive piece of work to review all the risk assessments. And as you would expect, some are very, very good and some people need some further support. So we have done that piece of work as well. So that's been a core focus. And on the second part of the question, which was about the training, that, as I've said, that's why we had that hierarchy of training depending on where people sit. And one of the things we will need to do, Ronnie, once and hopefully this policy is approved, is start to monitor compliance against that as well, because at this moment in time we monitor compliance against the training which we've set, which is statutory, which is the basic training. This takes us to the next stage of development in terms of managers and manager skills across the organisation. Oh, near miss, sorry, and then the near miss, sorry. Not doing very well with this, am I, Ronnie? Sorry. And then the near miss, obviously the health and safety team are involved with all incidents that are reported. So where there is a daytext issue in relation to health and safety, that issue is always reviewed, and those issues are reported through the health and safety group in terms of any lessons that we can learn.
Thank you.
You happy with that, Ronnie?
Thank you.
Right, I think we've had some reasonable discussion there and some suggestions made. So subject to the implementation of a couple of suggestions, can we approve that policy, please? Yes, thank you very much. Right, now I'm just making sure I'm actually in the right place on the agenda. Agenda item 2.6 next. This is the, the risk management framework and risk appetite statement. Rani's baby, this one. I know she's been keen on this, and we're grateful, Rani, for the work you've done on this, even though you're just about to leave us. Can we just, would you like to introduce that then?
Happy to, thanks. So this paper provides the board with the risk management framework, inclusive of the risk appetite statement, for approval following annual review and updating. The framework aims to set out the components that provide the foundation and our organisational arrangements for supporting risk management processes. The framework was presented to the Audit, Risk and Assurance Committee for comment on the 16th of November ahead of presentation today, and it has also been presented to the Executive Committee and Risk and Assurance Group for comment. The risk management framework has been reviewed following its approval in September 2019, and minor amendments have been made. These mainly relate to training, and the changes are set out in the cover paper. A risk management toolkit has now been developed, which provides guidance and templates to support services to actively manage risks, and this is appended to the framework. And then the risk appetite statement included within the framework sets out the board's strategic approach to risk taking by defining risk appetite thresholds. And this should be regularly reviewed and modified so that any changes to the organisation's strategy, objectives and capacity to manage risk can be properly reflected. So following review, there are no changes suggested to the risk appetite statement at this time, meaning that the board has a lower appetite for risk taking around quality, regulation and compliance, and a higher appetite in respect of strategic change and innovation. However, it is recognised that given the impact of the pandemic in particular, that we will need to take informed decision making at the most appropriate time, and this may mean that there are circumstances where decisions and actions are not taken in line with the risk appetite of the board. And in this context, risk tolerance will be key. So the corporate risk register is included later on the agenda and seeks the board's consideration of risk levels, including targets and tolerance. Thanks, Chair.
Okay, thank you. Are there any questions? And this has already been considered. Robert.
Yeah, just a clarification, Rani, again. Obviously, at the moment we have, we're struggling to provide the provision we would like to do so. So my question once again really is about how this is manifested. You just mentioned a little bit, but you can just tease that out, because does it mean that if things, for example, were to deteriorate further, that our risk appetite or tolerance would change, or is this simply reflected in the risk register? Can we just clarify that for me? Thank you.
Yeah, of course. Thanks, Robert. So my view would be that the risk appetite of the board is relatively set in terms of where it would seek to take risk. So we may, the board in this context of the current appetite, would seek to take greater level of risk around innovation and service change, which may in doing so mitigate risks around quality and safety, etc. But we recognising that much of our risk mitigation at the moment is outside of our control, the board may need to tolerate a level of risk that we're holding that is outside of the appetite thresholds that the board would like to operate within. I think otherwise the board would be saying that we would be happy to take risks at a higher level rather than tolerate them. So I think that is a conversation for the board to have about its position where it feels safe in terms of the capacity to take greater level risks. In terms of, so if you take quality as an example, do we have the capacity to manage effectively risks around quality at a higher level, or do we need to tolerate that we would ideally want to take a lower level risk, but some of that mitigation is outside of the levels that we would want to and expect at this time.
Okay, so we look forward to that conversation, Rani. We'll let you know how we get on. Okay, thank you.
Rani, yes, you're not suggesting that we get into that now, are you?
No, I do think, as I said, when we get to the corporate risk register later on the agenda, I do think we can tease some of that out. So, in terms of access to services, are we confident we're doing all that we possibly can at this moment, and we therefore need to tolerate the level of risk we hold, or are we willing to take a greater level of risk in that context?
Yeah, so I see what you're saying. Yeah, of course. Okay, thank you. Thank you for raising that. Melanie.
Thank you, Chair. Mine was pretty much around the same conversation around risk and our tolerance as a board, and maybe a plea for us to be mindful of when if we want to be adverse to risk, what that actually means, because as an outgoing vice chair and a quality and safety chair, I think that we really do need to understand, if we're adverse to risk, what that impact can be as a board, and maybe we need to be braver. So I shall put that there. Going forward, maybe that could be part of your discussions about projecting yourselves out there and doing a bit of blue sky as well. So thank you.
Thanks, Mel. Carol.
Yeah, thanks very much. If I can just follow on from Mel, I think that's exactly why the risk appetite statement around innovation is higher, because actually we have got to innovate to be able to create more sustainable services for the longer term, and we need to be bold. And so hopefully that one is helpfully set out in that regard, because there are risks to doing nothing, and that's important. Really, my main point was to come back to Robert's sort of query and clarification. Robert, I think with the next paper that we've got about system resilience and urgent and emergency care is a real example of what Rani was saying there, where our appetite would be low in terms of quality and safety, but the circumstances we find ourselves in and the external, if you like, pressures and influences means that actually the risk, looks to be higher than the appetite that we've set. So there's a, if you like, a bad way of putting it, but in theory, this is what we want. In practice, actually, there are circumstances that happen that mean it's very difficult to achieve that risk appetite statement. And that's the type of, I think, discussion that Rani's prompting us to have. So we might be able to have a bit of it in that context on the next item.
Yeah, thank you, Carol. Is everyone clear on that? I mean, I can see what I'm very clear on it. Thank you. And thank you for all the work you've done on this, Rani. We're being asked to approve the risk management framework inclusive of its risk appetite statement. Is everyone content to do that? Yes? Thank you very much.
Thank you.
Now we are scheduled to have a break, but I think we're ahead of ourselves. Would you be happy to carry on now, or would you want your break now? Any views? Carol?
Well, I'm content to carry on. Maybe this paper will flow from the previous item. Yes. It is for discussion, not for ratification, and maybe that will take us to the break. Yeah.
Thank you. I thought so. As long as Kate is happy about that. You're leading, though, Carol, aren't you?
I am on the system resilience.
Yes.
So thanks very much, Chair. Thank you, members. The paper that has been provided is an update paper, and it does flow very nicely from the risk management discussion that we've just had. The purpose of the paper is to update the board in relation to the progress that we're making in terms of system resilience and winter planning. At the board in September, we considered a high-level system resilience approach and wanted to take the opportunity before we head into the most core and pressured part of the winter to update on the progress and to outline some of the risks that we are still seeking to manage. So you will recall that at the September meeting, we touched on the significant pressure that there had been through the summer period, which was probably akin to most winter periods pressure. That pressure has not abated, particularly since our September meeting. But what we have been able to do is to really seek to focus and strengthen the system of working for the winter period, and hence we are going to give a bit of an outline of how we've been approaching this and the progress to date and the work still left to do. Since our meeting in September, the Welsh Government has published its Health and Social Care Winter Plan, and I've listed out there the key aspects of the plan as put together by the Welsh Government. Our own partnership plan, we shared the headlines of that earlier in the September board meeting. If I can just pull out a couple of the principles that the Welsh Government are asking us to manage, you'll see the 5 areas of harm there. That does reflect the earlier planning framework discussion that we had, so you'll see the themes coming through there, and you'll see the statements that the Welsh Government is seeking to achieve. We had a accountability meeting with Welsh Government on the 27th of October. That was really to test our preparation that is underway in terms of how robust we are in understanding the key areas of pressure in our own health and care system and the response that we plan to put in place. I have included in the paper the key summary response that the meeting drew out, and these are points that we largely reflected to the Welsh Government. The only point that was additional was the hear and treat rates, and we are investigating those to understand them in more detail. Other than that, my own sense is we have a good understanding of where the pressures are in our own health and care system. In terms of the local update, therefore, the things that we're doing about this, we have put in place, re-established the delivery coordination group, and I'm very grateful to Hayley in her Deputy Chief Exec and Planning and Performance Director role that she is leading this group. It is a multi-agency group because the issues that we need to work on are partnership issues as well as single organisational issues from the Health Board point of view. My counterpart in Powys County Council and I have met with Hayley and colleagues from the local authority, and we've agreed that each month we will review progress unless there is an escalation, at which any time Hayley and colleagues via the DCG can push the button on that. And Chair, as I know you know, we touched on this in our discussions with the leader of Powys County Council and the Chief Executive earlier this week, and we continue to have those monthly catch-ups. The Regional Partnership Board will tomorrow consider the partnership approach, because we do need to respond to Welsh Government in terms of the actions we're planning to take. And there has been some winter funding allocated to support that plan. Not all of the actions that will enable us to be as resilient as possible are solely within the winter plan itself. So I wanted to draw attention to the Welsh Government Coronavirus Control Plan. So colleagues such as Stuart are juggling a number of plans at the moment, and I just wanted to raise your awareness to that. A couple of other final areas before I close. We have a really specific focus on seeking to reduce the delays for our patients who are in community hospitals for their ongoing care. We have a significant challenge on our hands in terms of people being delayed. Some are awaiting admission or transfer back to a care home, and care homes have been affected by issues such as COVID, the matters of staffing and workforce challenges, and other regulatory type issues, which means that a significant number have been closed to admissions. We're expecting some revised national guidance to be published imminently, which may well help the situation. One of the other factors for people staying longer is assessment processes. So we have an agreement to change those assessment processes to support people to recover and then be assessed in their usual place of residence wherever possible. And that will be supported by some of the winter funding. I want to draw attention to enhanced resourcing in the third sector. It isn't a huge amount, but it will be well spent, I believe. I want to also draw attention to the work from a workforce point of view, and I recognise there are a number of exec team colleagues who may wish to comment on some of these, but really seeking to have as resilient a workforce for our community hospitals as possible. And then finally, I do want to flag that the military support into the Welsh Ambulance Service is an important feature since we last met. I'm going through the detail a little bit, Chair, because I recognise the paper came separately to the main bundle. There are a number of risks that we are trying to manage and mitigate at this stage. I have just put the headline ones there, and we will discuss the risk register later on in the meeting. But I would also ask executive colleagues, if anyone wants to come in to elaborate on any of their areas, to feel free to do so. Back to you, Chair.
Okay, thank you. Can I just bring Robert in before we ask if any of the execs want to come in?
Thanks. A really important paper. I'm sure there'll be lots of interest in what's in here. I've got two questions though. The first is hidden away in the summary response for the from the 27th of October meeting is actually some very good news about WAST. Positive discussion with WAST has reached agreement that once emergency vehicles are released, they will return to Powys. And as you'll be aware, lots of people in the community you know, have raised this as an issue. Of course, probably the bigger issue is still about how long they are waiting to be released, but nevertheless, this is a major step forward, and wondering there for how we will monitor that. That's question one. And then question two, really, the first bullet point about how we could use the MIUs better. And I'm just wondering what that model will look like. How could we, you know, would we have a GP attached to it, you know, day and night? I don't know. Thank you.
Yes, thanks very much. I wonder if I might bring Kate in on both of those, particularly around monitoring WAST. And the key element for us, Robert, is still going through a focus on each time an ambulance is delayed to a life-threatening call, what are the consequences and outcomes of that, and tracking that back. Could that have been prevented with other processes? But again, members of the public watching this meeting may not be aware that we held a board development session with the Emergency Ambulances Services Commissioner and the Welsh Ambulance Services Trust, and those reassurances that were given to us during that forum about the improved access for Powys being well understood. So I'll look to bring Kate in at this point, if that's okay. Thanks, Kate.
Thank you. So yeah, so with regards to WAST, then we're obviously having a huge amount of conversation with them so that we understand the position both at a local level and a national level. The pressures are like none that any of us have ever known, and the delays and the stretch on the system is significant. From a Powys point of view, what we're doing is we are logging incidents and feeding them back, and as much as anything, just keeping the dialogue going. So we have now assurance that I think it's understood that Powys is especially vulnerable with its geography, and with assurance that ambulances will be released back into county as quickly as possible. We are also working with WAST. We know that not only about 60% of the 999 calls actually result in a conveyance to hospital. So we're doing some work, and that again, that's taking place nationally as well, to see whether there's anything we can do to prevent some of those ambulances being dispatched in the first place. So that's work in hand. Very much what we're doing at the moment. There are a huge number of things we could do, but at the moment we're focusing on what we think we can deliver and that will have impact very quickly. So those are our first priorities, and that's one area that we're just having some conversations about at the moment. So watching it very, very carefully indeed, and feeding back on a regular basis to WAST with lots of dialogue. In terms of minor injuries units, and again, we know that actually the numbers going through are relatively low at the moment, but during COVID, we have changed the way we practice in that we are triaging calls, so the activity is higher than it looks. but we're having conversations with the MIUs to scope what else they could do. Again, what we do at the moment is it's balancing risk. We have significant issues with staffing across the organisation, and much of that is due to COVID. And so what we've got to be very careful is that we don't overload another part of the system by a change in practice, but we are scoping whether there's any more activity we can put through MIUs as we speak. So if there are things we can do that we think won't impact elsewhere, we will, but some of them may have training implications, so it might not be deliverable immediately.
Thank you very much, Kate.
I don't know if Hayley wanted to come in on this point, or, well, you're next anyway, I think, Hayley, so please do come in.
It was a slightly separate point, but it's just reassuring the board, really. The delivery coordination team is going into its 3rd week of meeting now, and it's that partnership working that we're requiring across the local authority, and also importantly the 3rd sector are playing a really important role through PAVA representation in that meeting. I think that just to give you a bit of an insight, we're looking across the whole system, so we get escalations from our neighbouring health boards. We know the position around WAST. We share information across social care pressures within our community and primary care services. And I wanted to just mention, I think primary care are under tremendous pressure currently, and how we work with our primary care colleagues will be really important as well in this. I think that we have made some quite shifts in thinking around a couple of aspects over the last couple of weeks, and it'll be interesting. The proof of the pudding will be whether that has a direct impact on some of the flow and numbers that are coming through. So hopefully we'll be able to report progress on that over the next couple of weeks, but just reassuring really the board that we're all hands on deck around this now as a whole partnership and as a whole system, because the direct correlation with our ability to manage system resilience will have a knock-on effect potentially on other aspects, including planned care and our ability to do that work. So I just wanted to thank colleagues, not only within the health board across all levels, but also the local authority and the 3rd sector for being so proactive in being around the table to try and resolve this currently. Thanks.
Thank you, Hayley. Ian is next, and then Julie wants to come in.
Thanks, Chair. Just a couple of things on the Welsh Government feedback. Thanks, Kate, for the feedback in relation to the MIU and that there's work going on there. I'm particularly focusing on, I guess, the pressure on primary care at the moment. I just wanted to ask in relation to the other bit that will affect primary care, no doubt, which was the 111 abandoned calls, whether there's work ongoing nationally to look at that and whether we're likely to see an improvement.
Shall I come in? So yeah, there's a huge amount of conversation in several arenas, but certainly within the medical director and director of nursing arena, then we've had a lot of joined up work, and that is one of the focuses. There are several areas of focus that we have grouped together to suggest, and they're not surprising, they're all the things that we've discussed really, but 111 is one of them in terms of those lost calls, which is key. So there's a lot of work on and making sure we are managing the demand, describing the demand, and trying to ensure that we are dealing with patients in the right way the first time. So yeah, that absolutely is being looked at.
Thanks, Kate.
Thank you. Julie, would you like to come in?
Yes, please, Viv. I know that workforce was mentioned earlier on. It would be remiss if I didn't talk about the work that's happening. I think we are all minded. We all know what the risk score is in terms of the risk around workforce. But from a positive note, there's some really exciting work happening, particularly within the community services, where we are considering our staffing at a ward level, the different types of roles we can introduce. And that work will be coming forward to the executive team on the 1st of December. And I have to say, certainly Supia's, Vic Deakins and my team have been working really, really well together, along with the clinical services managers, to look at something that really helps us to address our issues, but also provides a new and innovative approach to workforce, which supports the Workforce Futures framework and the strategic direction of travel. Just to note, we are really pleased that we will be having our people who will be joining us to take healthcare support worker roles and to undertake their nurse training. That's an additional support into the organisation. And just to put this in context, myself, Carol and other execs have been invited to a national workforce summit where we will be looking at how we resolve the issue, perhaps on a national level, but we're starting to get into one which is not about recruitment and retention, it's about demographics and what we're going to do for the long-term future. Also, from a positive note, we have built on the success of the volunteers and the MOU we have with Parvo, and we are looking at some really exciting options of deploying volunteers to support our patients who are within a ward in a really productive way, recognising the core role that volunteers can help in enriching the experience that our patients have within our hospital setting. And I know that there's a wider piece of work which we'll be looking at in terms of modernisation of services such as district nursing, etc. I think just one point of note, as a health board, we have been worried about our supply of clinical staff, and that's touched on almost every conversation we have about service development. And I just have to note that that is now extending into other groups as well. So administrative staff, managers, the whole range of areas, but that's not unique to Powys. So it is quite a difficult and challenging arena across Wales and across the UK.
Yeah, quite. Thank you, Julie. Well, there's a lot in there, isn't there? And does anybody want to make any more comments or ask any more questions? And we've had a good discussion and we know what the issues are. And of course, we're supportive, but we're being asked now to register formally our support for the work that's currently underway and note the risks that need to be managed. Everyone happy to do that?
Thank you, Chair. Thanks all.
Thank you. Well, now, if we have a break now, Kate is due to come in with Jamie after that break. Would that suit you, Kate and Jamie? Because sometimes people have things set up that they have to do over a certain time, lunchtime or whatever. So we could have 3/4 of an hour from now, or we could come back at past. Yeah, everyone happy to come back at past then?
Yeah.
Thank you very much. Thanks, everyone. Hello, everybody. I don't know whether everyone's back yet. I hope so. I think probably everybody is. So we'll carry on, please. Is everyone who can hear me happy about that? Good, thank you. We'll carry on then with Kate and the priorities on renewal.
Thank you, Chair. So the paper is giving you an update on the frailty project. So I'll give you the sort of important summaries. I think we're pretty familiar with the content and the plan, but to the progress being made. So we now have our PID written, signed off and agreed, and the programme board is formed and will be meeting very shortly for its first meeting. So the paper, it describes the transformational changes. We have our existing frailty model, but there are areas that we know that we need to transform to enhance it. So the paper describes that, but it also describes the fact that given our previous discussion about the system pressures, we've had a change in emphasis and focus on some of the areas and accelerated some of them, and especially the ones we think will help to stabilise the system and give us a bit more stability during the winter. So we'll go through, we've just discussed those in the systems resilience discussion earlier. The paper describes the overarching model, and that really is one of being more proactive rather than reactive in our approach to frailty. So more of an emphasis on planning ahead, planned care and prevention. So more defined models, so the use of our community hospitals, much more defined use of them, patients going in for clear purpose and clear focus on what is needed. Very much an MDT approach, looking at areas of prevention, so admission prevention with the virtual wards, and early rescue when patients do need to go into hospital to make sure we get them home as quickly as possible. So one of the overarching principles is to keep people safe and well at home for as long as possible. Focus on screening with frailty screening and the complex geriatric assessment, which we know improves outcomes. It improves survival, and it also reduces the pace of deconditioning. So we know that's the right thing to do, and we're starting work on our frailty screening, and we'll roll that out to complex geriatric assessment as we progress. I think the only other headline is that we're very much applying a value-based approach to this, concentrating on outcomes, concentrating on patient experience, which will be collecting data on and gathering as we go. So one of our first objectives will be to outline our outcome measures, which we'll start to measure from the beginning, then we can measure our success. I'll stop there because I think we've probably, most of the rest of the material we covered, but very happy to take any questions.
Thank you. This is something we are familiar with. Katie.
Thank you, Chair. Thank you very much, Kate. This sort of relates, I suppose, to both this paper and the next paper that Jamie's presenting. Hayley's been updating us about the renewal programme, but I would really value and welcome from a CHC perspective just a bit more of a discussion around the sort of content of this paper and Jamie's. I'm just saying this now so that I don't put my hand up in Jamie's session as well. So if we could just perhaps outside of this meeting have a discussion from a CHC perspective, I'd be really grateful.
Of course, I'd be really happy to do that, Katie.
Thank you.
Yes, thank you, Katie. It is important from your perspective. I see that. Ian.
Yes, thanks, Chair. Thanks for this paper. Just a question really in relation to the project management arrangements of this, which you outline on page 10. I just wondered about the wider arrangements. I'm picking up on Julie's point about the difficulties in recruiting staff at the moment. I wondered whether do we have an adequately resourced and dedicated project team, or are people picking this up in addition to the day jobs, bearing in mind the importance of this and the pressures that our staff have been under for the last couple of years?
Thank you, Ian. So actually we have been linking in with the North Powys project because there's a lot of it's very similar work, but we have just been given a senior project manager who is absolutely going to be key in helping us take some of this work forwards. So that's going to that's definitely going to boost our progress, I'm sure. So that's very welcome.
Okay, thank you, Kathy.
Morning, everybody. I was just going to inquire, do we have a robust communications plan for within the health board and externally as well? Because a lot of this will involve the culture of people expecting to go into hospital and not stay at home.
Yeah, good point.
Thank you. Very good point, Kathy. Thanks for that. And I should have mentioned that. So I think it is work in progress, and you're absolutely right. Key to this is culture, and it links into our previous conversation about balance of risk and understanding risk and harm. And I think one of our major challenges is to raise awareness of the amount of harm that comes from holding people in hospital too long. So well-intended acts can lead to harm. And so that is a key part of the project and actually a key part of our system resilience response. In terms of how we do that, then we are doing some work from a learning group on just engaging our various staff groups to see how they would best like to receive information, because I think it's different and people like to receive information in different ways. So we're doing some work on that. But in terms of this is very much, I think, about leadership and about us all getting out into clinical areas and cascading the messages and repeated messaging. We know that one-off messages don't work and that we need to repeatedly message and use things like patient stories and examples, which can be really, really powerful. So that's a major part of our system resilience work, is to really, really get people to understand where we are and the risks and the benefits of getting people treated in the right places. And I think it's for all of us, and that's very much work in progress.
Thank you. One thing that we can't probably do at the moment is have patient stories, but it would be nice at some point to hear how this is working through from that perspective, Kate. Trish.
Thank you. Yeah, thank you for the paper, and I think my comment probably applies to both this paper and the next one. It is important that we communicate and enable our staff and our population to understand what's happening, but it is also important, as we're changing services to and cultures, to listen to what they have to say and get the experience back. So we need to close the loop. I'd like to know, have we got plans for that?
So actually, another very good question. So yes, so really importantly, been out onto some of the wards, spoken to staff, engaged with staff to really understand what the issues are. I attended the virtual ward at in Llanfwclan last week, which was absolutely brilliant. So I sat through it. I was so impressed. The people that we are looking after in their own. So the virtual ward is a multidisciplinary team looking after patients who might normally end up in hospital at home, and the work that they were doing was just brilliant. And so but by doing that sort of work, you really get an understanding of how the system's working. You get the feedback. So that is a major part of the project. I'm certainly getting out and about as much as I can, and I know others are as well. So absolutely, really, really important.
Thank you.
Claire?
I just want to come in with some reassurance. We're hoping to re-establish the patient stories again from the new year. So we'll be really pleased to bring those to you.
Thank you very much. I really enjoyed that aspect of meetings. Thanks. Mel.
Could I just make a sort of plea that if we are able to get out and about again, the independent members are also involved in that conversation. I know that everyone's been really keen to try and also really respectful, obviously, in the last couple of years because of the position we're in. But I know that we've talked about it as independent members, and Viv will support me on that, I know, about wanting to be out as well. So maybe in small groups or individually, that would be really nice if the directors, if they're out now, could start maybe contacting us individually to maybe enhance that, just so that we start that process back up. Thank you.
Thank you. Right, are there any more questions or comments? Jamie, I think then, would you like to come in, please?
Thanks, Chair. I do think I see Claire Manson's hand still up from that. Claire? Sorry, Chair.
Oh, sorry. Right.
No, she's put it down now, Chair, so it must be the legacy hand. I apologise.
Okay.
I was just checking. She didn't want me to comment first.
Right.
Thanks, colleagues. I think there's a great symmetry between this paper and the one that Kate's taken, so I appreciate some of the similar comments, and I'm sure, Katie, we would welcome a chat around that for this particular programme. They are quite different, Of course, so colleagues will note the detailed paper and the update for the Diagnostics, Ambulatory and Planned Care programme within the renewal portfolio. The position on performance on waiting times and RTT, as we call it, is not covered in this paper. That's covered in wider reports. I think the next report we cover off will cover that off. But I'd welcome colleagues to note the positive progress within the Health Board on the activity it's been delivering in line with its plans to Welsh Government within the paper. The paper itself therefore focuses on the programme, not necessarily a normal operational delivery. The programme aims to ensure recovery is based on creating sustainable services whilst dealing with the backlog, which of course is a key metric and measure for patients who are waiting on our lists within the Health Board as well as outside. We do now have a programme manager, so picking up on Ian's comment on Kate's paper, we have a dedicated programme manager. Cara, who only really came into post in the last few weeks, is a fantastic welcome addition to it. But I think it needs to be fair, Ian, that by default a lot of work still will rest within the teams on a daily basis to ensure that the work is done. Cara is only one person and cannot do it all, so it is a great addition to help pull it all together, but there's going to be a lot of work done by the operational teams and other colleagues within planning and corporate teams as well to drive forward this programme at pace. I think page 3 to 4 summarises the key elements of the work on planned care. A lot of that actually is ongoing, but also driven by the national work on the planned care programme from Welsh Government, which predates COVID, but has been definitely rejigged and looked at with focus on things according to the experiences of the COVID pandemic, but also sadly the rapid deterioration in waiting times across Wales and England. Okay, the key element of the work at the moment, the focus of the planned care work has been insourcing. So we've been working to insource additional capacity. That has yielded benefits, and the mobilisation plan is being worked up in detail right now, and we'll see the benefits of that for endoscopy and general surgery in the last quarter of this financial year, which will be a great boost to patients waiting on those waiting lists. For wider specialties, that's been progressed in line with normal operational processes, and later reports on performance will see some of the benefits and the progress already in place for that. In terms of diagnostics, paper outlines the key work being led now. Actually, Claire Lyons, our Assistant Director of Transformation and Value, has been personally driving this piece of conversation linked to other pieces of work. The benefits of a portfolio over a programme is that this will benefit not just this particular piece of work of diagnostics, but the wider elements such as frailty and how we manage that. So Claire is leading the work with other colleagues on developing that pace diagnostic strategy. The third strand probably is the least worked up at this stage, which is the ambulatory care. It is associated very much with the work that Kate talked about in frailty, but also the level of diagnostics we can provide within Powys will dramatically benefit and impact on the level of work we can do in an ambulatory fashion within the boundaries of Powys Health Board. So that's the link of those two. So, but we will be developing that at pace going forward into the new calendar year. So board is asked to note and discuss the update and the work of the specific programme within the renewal portfolio and the work that's carrying on under that banner.
Thank you. Thanks, Jamie. I think Ian's got a question for you.
Thanks, Chair. I should have said last time when I came in last time, really great to see a huge amount of work going on in terms of modernisation and innovation and supporting our strategic plan. A specific question on this really is around the virtual stuff around outpatients, both new and follow-up. Clearly it's only 2 points, but I note the reduction in Q2 and just wonder whether we've got any intelligence at this stage whether that's an appropriate reduction in numbers, or are we starting to see if you like people revert into old ways of working?
I think the note, I think I wouldn't have the detail on that, Ian, and I think it's a valid question to pick up. It is noted we've seen that decrease. I think what it is that we've seen clinicians opt in to see particular patients face to face because they've waited longer. So it is a personal choice by the clinicians of how they can handle a patient accordingly, and the patient's choice as well. But we still try to promote at all opportunities a virtual model. It is better for a patient to save them travelling a long way for a procedure. It is better for clinicians, it's quicker for clinicians as well to process patients through. So it does mean that we get more patients through the system, which is important for patients at the moment. But I think it's a balance. I think it's too early to diagnose a trend, Ian, is my personal view. We need to keep an eye on this to make sure we're not going back to the ways we did before, which is seeing everyone face to face. The other push as well as just virtual is things like see-on symptom and patient-initiated follow-ups. So I think it's too early to start a trend, other than some clinicians are very clear that there are certain patients they would now need to see.
That's helpful. Thanks, Jamie, and one to keep an eye on, presumably.
Yeah, thanks.
Now, Kate, did you want to come in on this point, or Oh,
yeah, I think Jamie just covered it almost, but I was just going to say, I think we've seen an increase in referrals rising back to pre-pandemic levels of late. And I think for many outpatient reviews, then the first review often needs to be a face-to-face. So that may be why we've seen a change in proportion. But as those patients are seen and the follow-ups occur, then often it's the follow-ups that are much more suitable for a virtual appointment. So that may be why we've seen a change in trend, but time will tell.
Okay.
Thank you, Kate.
Ronnie, you were next.
Thank you. Jamie, you mentioned endoscopy and insourcing. I suppose I asked this question against the background that there's one weight recorded for colonoscopy of 54 weeks. Will the process of insourcing affect JAG accreditation?
No, sorry, I can see Carol shaking her head before I can even turn my mute off. No, it won't. We'll ensure that the insourcing departments are compliant with that and work to those standards that we've worked hard to attain within Powys. I think the key thing is you will know that, I think I've stated before in performance reports, Powys was doing very well even during COVID, and come to March we were very good on that. We've had some particular staffing issues and challenges which have seen that deterioration. This will allow us to get back to that steady state prior to that, but JAG accreditation is important to Powys as a health board, and it wouldn't be an impact on that. I think insourcing as a phrase, so for those, sorry, it's a jargon phrase, we are bringing clinicians into our teams as opposed to sending our patients out of our borders. So that's insourcing. We're very clear to make sure we don't run into jeopardise the JAG accreditation, and working closely with the provider as part of the procurement process to ensure that.
Thank you. Well, JAG accreditation is important to me too, Jamie.
Yeah, I'm sure it is, funny, but it's so we're all on the same page on that one.
Thank you.
Okay, thank you, Ron. Well, we've had a good discussion, and we'll note what we've read and heard, and of course we're very supportive, and it's great to see progress being made. So thank you, everybody. I think we can move on now to the next agenda item, and that's performance reporting. I think Hayley, would you like to lead on this?
Ie, diolch Cadeirydd, diolch am y cyfle i gyflwyno'r adroddiad perfformiad diweddaraf i'r bwrdd. Thank you, Chair. This report is in two parts. The first part of the report, 3.3a, provides a high-level summary of the performance position against the National Delivery Framework. This report was considered in detail at the Delivery and Performance Committee held on the 1st of November. So highlighting some key points, the report takes the detail that was available when it was written around the COVID incidence rate, and I know that Steve will probably pick up in a minute just the latest position, but the report sets out the position as at 13th of October and the cumulative position of the number of residents that have had a positive test outcome is 10,278. And obviously the latest 7-day rolling rate in the report as well is at 493.8 cases per 100,000 with a test positivity rate of 15.8%. So really concerning numbers there, but I'll ask Stuart to come in with the latest position in a little bit. In relation to the deployment of the vaccination programme, we're continuing to make good progress. Powys continues to be the health board with the highest first dose at 91.2% and second dose at 89.2% for people over 18. Our first dose vaccination rates for 16 to 17-year-olds is 84.3% currently, and 12 to 15-year-olds is at 63%, which again are the highest of all health boards in Wales. The JCVI approved on the 15th of November the second doses for 16 to 17-year-olds, and we're just working through that detail at the moment. And we've passed the huge milestone of delivering over 250,000 vaccines through the programme in Powys. And of that, we've delivered now, as of I think it was yesterday morning, 43,700 boosters at the interval of between 26 and 28 weeks after the second dose. So really positive progress in terms of our COVID response around both test, trace, protect and vaccination. In terms of the unscheduled care and system resilience presentation that you had earlier, obviously there's significant pressure in the system currently and unfortunately WAST Red response time performance continues not to meet the target. And also you'll see contained within the report on page 18 the issues across our providers around the waiting time performance for A&Es against the 4-hour and 12-hour metrics. So the pressures in the unscheduled and urgent care system are significant and very challenging. And clearly our success in managing our response to this will also has a direct correlation to the ability of providers to undertake planned care activity. The planned care position, I'll ask Jamie to come in a minute just to give some reflections on as a provider, but we still have a significant backlog of people awaiting treatment. We have now 4,428 patients waiting over 36 weeks for treatment across Welsh and English providers. But in Powys as a provider, in September we had a total of 227 waiting longer than 52 weeks, which is showing an improving picture. And as Jamie mentioned in his earlier report, we're expecting further improvements in Q4 once we're able to mobilise the in-sourcing capacity as well. The key specialties, again, around planned care are similar across all providers across Wales and England, and they're trauma and orthopaedics, ophthalmology and general surgery. I'll also ask Kate to come in a little bit as well about the issues around cancer position, where obviously early detection is vital. So if I ask colleagues, if I come back to Stuart first and see, would you like to add any few points, Stuart, on either the COVID position or the progress with the public health prevention measures or flu programme, etc. to start with, and then I'll come to Jamie if that's okay.
Yeah, thank you, Hayley, and thank you, Chair. I'll just, if I can, just say a little bit of an update from Director Public Health point of view on where we are with COVID. And then in terms of flu vaccination, obviously to note the flu vaccination programme has now started, and we are actively in the flu vaccination season as of now and actively vaccinating. And Chair, it's really helpful to know that you've had your vaccine, so I know that from earlier, so thank you for that. If I go back to the COVID position, then just to give a slight sense of where we are as of today. I did, Chair, look back when we last met at the end of September at the numbers, what they looked like then, just to give board a bit of a sense of change between when we met at the end of September to late November. So back at the end of September, I was telling you that we were getting about 87 new cases a day of COVID-19 in Powys, and that about 13% of those people that were getting a PCR test were testing positive. Rolling the clock forward to yesterday's report, we're now up slightly, so we're getting 97 new cases a day of COVID-19 in Powys, and our positivity rate is at 18%. So both of those measures have gone up very slightly in that 2-month period since end of September to end of November. So we're getting about 700 new cases of COVID-19 each week, and that's still quite a high level of transmission happening in the community. We have to accept that. The positives, we are seeing that predominantly in younger age groups. So we've absolutely seen the impact of vaccination on 12 to 15-year-olds. We have seen a decline in infection rates in secondary school age children, and that's really welcome to see. But we are still seeing quite high levels of infection at primary school age, and then that's effectively transmitting then to parents. So we're getting a fairly high case incidence in 30 to 49-year-olds. So what we're seeing is patterns of household transmission, as we are everywhere in Wales. Just early signs of optimism. As I've mentioned, the vaccination programme on 12 to 15-year-olds has had an effect. We're also beginning, I think, to see the signs of the booster programme, particularly on all Wales level, have an impact. I get to see age-based case rates on a weekly basis, and it's clear that for some of the older age groups now, we're beginning to see a reduction in cases in the near term. So I think the importance of the booster programme cannot be underestimated in terms of helping us to get case rates down over the next few weeks and months. So I wanted to just acknowledge that hard work and the value of that work around the vaccination programme, if I could. And then just to finish, to say from a testing point of view, we are providing high levels of testing in Powys. We're just in the process of bringing in 2 more mobile testing units, so that will enhance our testing ability even more over the next few weeks and months. And we already offer testing for most age groups at a rate higher than the national average, and we will continue to make testing available as we go forward over the autumn winter as well. Thanks, Chair.
Thank you. Thank you.
Jamie, would you like to come in on any provider of mental health issues?
Yeah, thanks, Hayley. Thanks for that. Always happy to. I think obviously some of this is set within the context of the system resilience updates and other conversations we've had already, colleagues. At the high level things I would normally try and draw out from the paper, because it's a large paper with a lot of information, is our MIU delivery is 100% as we've come to expect. But the key issue for us remains the red performance for WAST within Powys. Colleagues will recall the discussion at board development with the Ambulance Commissioner and also the Chief Executive of WAST, but also the detailed report to the DNP committee earlier this month, which outlined the issues and the ongoing work on this very important matter for Powys as a health board and the population of Powys. In terms of diagnostics, the key challenges outlined in the paper are non-static ultrasound, although that is now improving since the data within this report. We have some staff returning and supplementing with additional staff. We've also mentioned endoscopy, covered off already in the previous paper. I've mentioned insourcing from that point of view, and that will show some benefits going forward into the last quarter, which will be important. Therapies has been improving throughout. We will see small fragilities in specific services during the winter period still. It does not take much to lose one member of staff, and that impact on our final performance in a period of time. We will have that period of sickness during winter. We have COVID, but also other factors. But I believe we'll be able to sustain delivery generally as the new posts arrive, but also just keeping an eye on our CMAT, our physio service in particular. So as for RTT, I always say this. It's difficult for me to sit here and celebrate the success of our improving position when we have still got patients waiting longer than we'd want. However, I have to note that the work has carried on. There's been further updates to planned care and also the focus on renewal. But I think I always have the benefit of more later information than the reports will tell you. But the 433 figure in the report of people waiting at the end of August over 36 weeks is now down to 305. So that shows once again the steady progress that's been carrying on, that will be increased, particularly with general surgery and endoscopy going forward into the last quarter. A lot of the work and effort goes into that, and our focus is on reducing those long waits continually during the winter period, recognising that some of the demand will come through the system, not people who referred earlier in the year. Our clinics are running at historical levels now pre-COVID, which is important because it means we're getting the throughput through. And you'll note in the previous paper the comment that we are delivering the capacity we assured Welsh Government we would do in the first 2 quarters, and our DNA which remain low. We are still exploring all other avenues that we possibly can. We're focusing on follow-ups as well. A lot of good work going on follow-ups. There's a focus on the mental health waiters in follow-ups, and we'll work that through. The other issues, mental health targets are there. We've been facing some pressures, staffing related in the past few months. I'm seeing some improvement in the numbers post that. I would expect us to return to our normally good position with mental health targets in the last quarter when it gets reported through to the board. We are seeing, as you know, an overall demand for mental health services, both in terms of acuity, but also raw numbers. Neurodevelopmental is another one I always flag up here. It remains a challenge. We have invested in that service. Positive recruitment has happened and will be in post this month. And what we see is a reduction in the number. Once we see the number of people waiting for the first appointment has slightly increased. Importantly, the number of people who've been waiting for their assessment to be concluded is now dramatically reducing, which is a really important step for those families, those children, to have the resolution and potentially the support they require going forward in the system. That's a very high level canter through, Hayley. I'm happy to take any questions from colleagues accordingly.
Thank you, Jamie. I just wanted to comment on cancer, and then maybe Alison is wanted to highlight on the quality and safety as well.
Thank you, Hayley. So yeah, just to give a few headlines re cancer. So obviously you'll be aware in Wales we have the single cancer pathway now that states that 75% of patients should have their treatment started within 62 days of referral. We are not there for most of our areas at the moment. The referrals have gone back up to, so there was a fall during the pandemic, the early stages, and they've now risen to pre-pandemic levels and then seem to be stabilising again. We receive information from all our Welsh providers, which you see in the table there, as of the spread of their breaches. From our English providers, through the commissioning assurance frameworks, we have detail of any of their cancer breaches with root cause analyses, which helps us. In terms of harm and prevention, then with our renewals work, then we're really trying to focus on areas that we think we can start to have the biggest impact, and the two areas that we are chasing are symptomatic fit testing, which tries to direct the right people to their investigation, first of all for colonoscopy, and access to rapid diagnostics. So we're doing some work to try and target the greatest number of patients we can, which is starting to have some traction, hopefully. Screening, just to mention screening, that has, much of that was halted during COVID, some of it continued. We know that we're still behind in some areas. There's a push on bowel screening now, and we know we are behind in lower bowel screening, although in Powys our numbers are very, very low as a provider. So with the insourcing and with our teams now catching up, we're confident that that will start to improve pretty quickly. Just in terms of specialty specifics, then in general, then the upper GI, breast, skin are performing better. We know that lower GI and urology have the longer waits at the moment. It's a little bit, it's not so straightforward as headline specific, because the different types of cancer are more time critical in terms of their treatment times. But that's where we are at the moment. We are very closely linked into the Welsh Cancer Network and working with them to make sure we are aligning our work and are tracking to their methodology. And our renewals and cancer tracking and harm team are gathering and will start to give us more information, more sort of value and quality information as we move forward, which will help to start to form our pathways as well. So we are not where we would like to be. In terms of the rest of Wales, we're basically tracking most of it. Most of them are commissioned. The provider service will hopefully catch up very quickly now, and we're looking very carefully at the commission services.
Thank you. And Alison, and then maybe Julie, not least at the end, perhaps just an overview of any workforce key points as well. But Alison, did you want to highlight any areas?
Yeah, diolch, Hayley, thank you. Board members who attend the Patient Experience, Quality and Safety Committee will be familiar with the regular reporting around our performance with regards to putting things right, and you'll notice on pages 371 or 38 of that report, there's an account of some slow but steady progress in our compliance with the 30-day target for completed response to people who submit a complaint. That figure is a really important figure that we are mindful of. The other main factor in our response rates is about the quality of the concern response we provide, and we continue to do quite a lot of work within that arena to make sure we get it right first time. Colleagues may also know there's an improvement plan associated with our putting things right function that's regularly reported to committee as well. My thought around this figure is there's an incremental improvement. It's slower than I would like. It is moving in the right direction, and I'm hoping now that we've spent the last 12 months undertaking a deep dive into this function and have got the foundations properly in place, that we'll see more of a step change in terms of our compliance next quarter.
Thank you, Alison. And then Julie, did you want to come in?
You there, Julie?
Sorry, I got stuck. I had a sticky mute button. I'm so sorry. You know, yeah, in terms of the performance data, again, we'll see that we're still not hitting the target that we would expect within PADR compliance, although compliance of 70% is a really big effort within the organisation. Just to say that I think this is an area that both, I know, executive team and the Workforce and Culture Committee will probably want to put further scrutiny on, and it is an area that all managers are aware of, but I think that the conversation narrative around pressure has been identified. However, appraisals are a core part of our wellbeing plan, in that the conversations that individuals are having with their managers are absolutely vital to individual well-being. So I would not want the board to think that that 70%, although it doesn't hit the target, has certainly come with a significant amount of effort and work across the organisation. In terms of what's been described in relation to sickness, I think we would expect to be seeing a rise in our sickness. We are still managing to control and monitor our approach to management of sickness absence, which includes a range of support mechanisms for our staff to enable them to be in work and to get back to work as soon as they possibly can. But we do recognise that the impact of COVID and other areas are having an impact on our normal sickness absence rates.
Thank you, Julie. And that's sort of a very summarised approach to the performance report, but there's part B paper as well, 45-page report around the narrative description of our progress against the milestones that we set in our annual plan against Q2 progress. We're not going to attempt to summarise that, colleagues, but I think you can see from the structure of that all of the areas that we contained within our annual plan, there's an outcome and sort of narrative for each one, which is summarised by each lead executive director. And I think generally we're making good progress against our annual plan milestones. And when you look at both reports together, I'm sure members may have additional questions they may want to ask us about. But I'd like to thank people for their contribution in bringing together the Q2 report. This is a requirement that we submit to Welsh Government after the board's discussion today. Thanks.
Oh, thank you for that. And a lot of work obviously has gone into this, and teamwork as well, which is lovely to see. Are there any questions from the independent members? No? It's very clear and very well set out and very well explained. And maybe there are
Chair.
Yes.
Yes, there are, Chair. Yeah.
I can't see the hands for some reason.
Yeah, sorry, I just saw Ian and Mark.
Right, just go for it. They're not showing on my screen, but do go for it, Ian, first then.
Okay, thank you. Yes, I'd reiterate what Viv said there, really clear and well laid out report. Just two questions, one on data and one for process. I don't want to stay first on data and the TTP. I've forgotten the first T now. Test, trace and protect. Sorry for that. I don't want to steal any of Carol's thunder from a report later on, but I was really fortunate to be present at the showcase event, which was incredible. And all I'd say at this stage is we are extremely blessed as a health board to have such dedicated, enthusiastic and hugely capable staff that came over in bucket loads. As far as the data is concerned, I came away from that meeting with a more positive view on the TTP figures than we're getting in this report, a much more positive view. So I just wondered if that's timescale or different data. And my second question is in relation to the flu vaccination and the process. It is concerning to see a low level of uptake by our staff. And two questions really. Do we know what the issues are, and are we making it easy for them?
Thank you, Ian. I'll ask Stuart to come in if that's okay for both those questions. Thanks.
Yeah, thanks very much, Ian. That's really helpful. I'll deal with the second one first. So a lot of that under issue with uptake is linked to data. So we're meeting weekly at the moment to look at the staff flu uptake figures, and yesterday's figures showed 34% of clinical staff had the vaccine, which is a lot higher than the figures that are reported in the paper. So there is a timeliness issue in relation to the data on staff flu vaccine. We probably started a week, 2 weeks, a bit slower than elsewhere, but we are monitoring this on pretty much a daily basis, and we think our uptake is significantly higher than it appears in that report, and the next one I think is due next week, and you will see a big hike in terms of uptake. Just in terms of the TTP figures, yes, I think I'm always conscious when I read the board papers that the real-time numbers on numbers of tests being done and positivity rates change, and they change quite frequently. But just in terms of numbers of tests, as I said, when you take all ages in the round, our overall testing rate is slightly below the Welsh average, but when you split that by certain age groups, particularly some of the other age groups, we test sort of way in excess of what they do elsewhere in Wales. Colleagues that were in a meeting recently, a JET meeting with me, will know that for school-age children, for example, we test about 28% higher than the rest of Wales. So the testing figures do vary. Overall, we're slightly lower than the Welsh average, but they do change and they do fluctuate because of the issue of timeliness of reporting.
Sorry, Stuart, I was particularly taken with the tracing figures rather than the testing figures. Sorry, I should have made that clear.
So within the tracing side, in terms of performance, there is, which you don't actually see in the figures, we have, we've switched within tracing across Wales to a prioritisation framework for tracing. So the overall levels of percentage of cases followed up within 24-48 hours and contacts followed up within 28-48 hours. To some extent within TTP at the moment, they're sort of, they're measures of performance, but they're not really the main focus of work at the moment because of the sheer number of cases. What we do have is a list now of 7 different prioritisation groups that we spend more of our time focusing on in terms of timeliness. So just to illustrate that, health and social care workers are the #1 priority group for follow-up within TTP. And so they triage cases when they come in at the moment. So those overall figures of performance do look poor actually against the standards. They're poor pretty much everywhere, and the reality within TTP at the moment that we are focusing on a more prioritisation approach rather than looking at every single case that comes in and following them up in the same way. What we're not able to do at the moment, which is a system everywhere in Wales, is what we're not able to do at the moment is performance report timeliness against each of those priority groups. So we still only report overall numbers of contacts and cases and timeliness of follow-up, but the main focus on us is making sure we apply that prioritisation framework in the right way. So we do some ad hoc work just trying to test where we are on some of those, but there isn't a reporting system yet in Wales that gives us a more nuanced distribution of timeliness against those groups. So the overall performance is a bit of an arbitrary measure at the moment because we're working to a prioritisation approach just because of the sheer number of cases.
That certainly explains the difference, and I think it's probably important to note that the figures that were being reported against that prioritised group were incredibly impressive from the snapshots that they took. Just to put that in context, I think is important for folk to understand.
Thank you, and go back to your original point. I did think that TTP event was a fantastic event actually, and just to acknowledge that for the purposes of board, for colleagues that were there, it was an extremely impressive and moving in some respects event. So I just echo your points on that as well, Ian, I think.
Okay, thank you, Ian and Stuart. Mark, you have a question or a comment?
Yeah, thank you, Chair. It's just something I picked up on when Kate gave us the update in terms of the cancer pathways, and comments she made how useful she finds the root cause analysis given from English providers. And I just wonder, in terms, I know we've got commission assurance framework, but what do we actually do as from providers in Wales in that respect?
Thanks, Mark. So at the moment, we don't have that level of detail, but that is something that we will be taking forward as part of the renewals plan and project. Then we have our cancer tracking team and harm review process, which will be digging down much more into individual patient journeys. So yeah, we don't get all that detail at the moment, but that is very much work in progress, and we're just literally recruited to those posts, or recruiting. We got a cancer lead in place, and very much what we will be doing is digging down into detail and then starting to scrutinise the pathways to make sure they're working optimally for patients.
Thank you.
Thank you. Well, thank you, everybody. I think we've covered that agenda item pretty thoroughly, and it's really good to see the progress that's being made. So thank you very much to the exec team and everyone working with them. So can we please go on to the next agenda item, which is the finance performance.
Thank you, Chair. So I'll just take everyone through the usual finance report in the usual format with the usual supporting papers. If I can take everyone's attention to page 2 of the finance report. So in summary, against our revenue position, we're currently £62,000 underspent, and we continue to forecast a position of break even. Against our capital resource limit, which has recently been adjusted to reflect our forecast spend to the end of the year, our limit is now 12.89 million and our spend to date is 2.3 million. Just to flag that spend on a sort of proportion basis looks low for the time of the year we're at, but there's a lot of work in progress and a lot of items which are scheduled for payment in the next few weeks and months, so that forecast is as accurate as we can be at this point. Okay. Within our financial position, just to flag on page 6 and page 7, our key cost pressure areas, ones that you've heard me talk about before, include our variable pay position, where our total pay spend is significantly higher than in previous years. It's detailed on the charts on page 6. Against our complex care and packages of care CHC position, which is detailed on page 7. And also to flag our ongoing block contract arrangements with our secondary care providers, both in Wales and England. The reason I flag the 3 areas is that the current position is included in our forecast to break even, but these areas contribute significantly to our opening plan position next year. They contribute, if you like, to our underlying deficit going forward, and the ask that will be included in our IMTP for 22 and on. Just then also to flag on page 8, our total forecast expenditure in relation to COVID, including both those direct and indirect costs, including mass vax, TTP, and all the other areas that the board would be familiar with, currently totals 31.8 million. Again, to note that as part of our the funding allocated in terms of the pandemic response from Welsh Government, those costs are covered within our financial position. And then just to flag the final point to really go through is on page 10. This details our current forecast opening plan position as we move into the 22 onwards IMTP. As we've been reporting in every board, in every subcommittee, we've been tracking our underlying deficit position. This underlying deficit position has been updated to reflect the cost pressures I just referenced earlier around variable pay, around CHC cases, and in relation to our potential block contract arrangements. It includes those areas where we've made decisions to invest recurrently. It includes the expectation of the benefits to be delivered against those investments. This links to our investments benefits group approach, and it also includes a level of assumption around savings delivery that's been built up in previous years. So currently, with further work to do on our plan, we'll look at an opening plan deficit for 22-23 of just under 9 million. What I will say at the moment is we're not 100% clear, as Hayley referenced earlier, in terms of what the financial allocation is going to be from Welsh Government, and we were expecting that indication around late December, as Hayley mentioned, but potentially a little later. And when we get that position, we'll be able to update the position further. But what I'm basically drawing the board's attention to is that there is going to be a significant financial challenge as we move into the next stage of the IMTP. We need to recognise this. We need to be clear on what that ask is. It will help us make those right decisions. And as we've all previously discussed, our whole approach should be around how we allocate the resource that we have, both financial and our our physical resource into the right place to deliver the best outcomes for our population. That is our whole method of approach to everything we're doing, and it is absolutely key for us to deliver sustainable services and sustainable financial position over the next few years. So I'll pause there, and as always, happy to take any questions or any points of detail. Thank you, Chair.
Thank you. Any questions? Can't see any hands up, but I don't know whether that's a good sign or not. I hope it's a good sign. Pete.
Thank you, Chair. I think it's a consistent messaging that we've been getting across month on month. I think I'm comforted with the awareness that suggests that people have and the understanding around the position ask. So thank you. I can see Carol wants to come in.
Carol's hand is up now, yeah.
Yeah, thanks very much. I think January's board meeting will be really important when we are considering the IMTP, and that the board to really understand how we are going to be managing the level of risk that we're carrying financially. We had an update yesterday from Welsh Government Finance colleagues to indicate how difficult the outlook does look, and in particular on capital, but also on revenue. So whilst there's been very many announcements on more funding for the NHS, it has not yet come all the way through. And as Hayley referenced earlier in the meeting when we were discussing the planning framework, we usually get the allocation letter very near to Christmas Eve. So we'll see what that looks like, and that will give us more opportunity, I think, to dissect that then in the January meeting.
Well, Carol, you'll be away then, I think, on leave, won't you?
I will.
Worry about that all over Christmas.
I'm sure there's not going to be very many surprises. It's going to be very tight, I think.
Of course, yeah. I appreciate that. Bound to be, isn't it? Right. So can we move on? Everyone happy to move on? Thank you. Thank you, Pete.
Chair, I think Tony was raising his hand.
Oh, I'm so sorry. I just can't see hands. Oh, I can't see Tony either. All right. Yes, please do come in, Tony.
Tony, you'll need to unmute.
I don't think anyone can hear Tony at the moment.
Can you hear me now?
Oh, yes, that's better. Thank you.
Can you hear me?
Yes.
I just wanted to clarify. Sorry, I was a bit slow off the mark, Chair. I wanted to clarify with Pete. I was reading an article about the likely English settlement for health finances, and obviously we get a consequential in line with that. Has he had any indication? England, and obviously Wales will benefit from that through the formula. Has Pete had any indication? That's all I wanted to query.
So thank you, Tony. So yes, we get the consequential allocation to Wales based on the English allocation. There has been some sort of high level reporting of those figures, what it means nationally for Wales. I guess for us it's understanding in that allocation how much of that is already committed towards things that are currently happening, like TTP, like mass vaccination. And I think when we do get our allocation letter, as said, as normally a gift on Christmas Eve, we can really understand what that means and what financial framework we will be operating in. We will be developing our plan based on assumptions with a little range, so we can start the work on that. And I think that will be key to us understanding what it means going forward. And just to add, a big reminder for everyone, the main reason for our developing underlying deficit or opening plan deficit ask is one, those cost pressure areas highlighted, but secondly, our inability to have delivered savings over the last couple of years, one, because of the block contract arrangements and a lot of our action impacts on that, and secondly, due to everyone's focus and commitment to the pandemic response, which is totally understandable. So in that allocation letter, there may be some sort of recognition of some of that, which will have a big impact on our plan. There may not. I don't know at this stage, but they're the key things we'll be looking for.
Right, thank you. Can we move on then? And
Okay.
the corporate risk.
Thanks for that, Chair.
Corporate risk register.
Yeah, thanks, Chair. So this paper provides the board with the November version of the corporate risk register. There are no suggested changes to the risk descriptions or scores since last reported in September. And in addition, there are no new risks escalated to the board for consideration. We did touch on earlier, as part of the risk management framework discussion, the need for a review of risk scores, targets and tolerance in terms of any variation against risk appetite. I don't know whether realistically, Chair, we're going to be able to work through the detail of that today, and I wonder whether I could suggest that respective committees for those risks take a more detailed review of risks and feedback to the board assurance regarding the tolerance levels.
Yeah, I think you're right. I don't think we can spend a lot of time on the detail of this, can we, today? Is everyone happy with that suggestion? Mark?
Sorry, Chair, there's only one quick point. I've been speaking to Pete and Ronnie about the corporate risk 002, which was the financial position. And the only thing I was suggesting there is that we just need a slightly longer time horizon, because I think it's a bit, I think we're going to be okay for this year, and I don't think that risk will change much, but as we go forward we can see from the position, and I think looking at it just on an annual basis, so I just wanted to raise it as something maybe for the to-do list. So thank you.
Yes,
that is good. Chair, I think it would be helpful for the board, as the IMTP is developed and signed off, that a reassessment of the corporate risk register is undertaken to understand any risks that could impact the achievement of those objectives for the coming year. So I think it's timely that we move into that more in-depth review in Q4.
Yeah, thank you. That's really sensible, Ronnie. Is everyone happy to do that? I mean, I think it's very difficult. There's a lot of uncertainty at the moment anyway, isn't there?
Thanks, Chair.
Okay. Are there any comments, any more questions or comments on that agenda item?
Trish?
Again, I can, oh yes, right, okay. Trish, sorry.
It takes me ages to mute. It's just looking at, or through the reports today, I'm wondering particularly about CR 006, and it's amber, but given the conversations that we've got today, is it higher than that? Is the likelihood more than 3? And is there anything that we need to do as a matter of urgency, or are we doing all that we can to mitigate the issue?
Thanks, Trish. I know Julie's commented on workforce during the meeting. I think it would be important for the Workforce and Culture Committee. There's an opportunity, the committee meets in January to discuss that risk in further detail and consider the scoring associated with that, because a large part of that agenda is scheduled to consider the risk and the work underway to mitigate that.
Yes. Okay.
May I come back on that, please, Chair?
Of course.
Is it, there's nothing that we need to do as a matter of urgency between now and January when we next meet, is there?
As a board, Trish, or as a, you know, there's a number of operational management issues that are in place and in train. Okay. So, and there's a whole programme of work that is progressing. It's not that we're sat there with this is the risk and our hands are tied. I can't tell you how much work is happening both within services and within the workforce team and within finance, costing, new establishments, etc. So as far as I'm aware, there's nothing that we need to do other than those things which we are doing. So, you know, that is a management response to dealing with the risks as we've identified them.
Okay, thank you, Julie. That's really helpful. And I know that you'll be doing all that you can. Thank you.
Thank you for that question, Trish. Right, shall we move on? to the next agenda item, which is Katie.
Thank you, Chair, and thank you once again for the opportunity to present my report. I hope it's fairly self-explanatory, but I just thought I'd make a couple of additional sort of comments and observations against it, really. Firstly, Adrian and Hayley reminded us last week that it's nearly a year now since the vaccination started in Powys, and I think it's really important to reflect that at the start of that process we were receiving numerous queries, concerns, people were a bit panicked, and I have to say every single one of those that we took up with the Health Board, a solution was found, and slowly and gradually those concerns were no longer there. And I have to say today and this week we continue to meet with Hayley and Adrian twice a week, and we're getting nothing but positive noise about the experiences that patients are having with the vaccination process. So I just think it's really important that you know, we as a CHC, but you as a health board also recognise the responsiveness that that team has had in actually finding solutions to individual and patients' queries, many of which were a form, but we're all very keen to fill in forms if it actually helps the process. I think from our perspective, we haven't been able to do any visits of GP surgeries or of hospitals over the last year. And we haven't done as many of our engagement activities for obvious reasons. So we're actually getting concerns that are coming in that probably would have been picked up usually through a visit or an engagement event. So what we're designing is, they're not complaints, they're concerns. So what we're looking at is actually capturing patient experiences, which actually, you know, can provide themes and look at patterns. I think it's interesting that if you look at the advocacy statistics, there are significantly more complaints for secondary care, but actually we're getting considerably more concerns around primary care, particularly GP and dentists. I think just the other thing I'd like to sort of reiterate, because it's cropped up a couple of times this morning or today, is that you know, we've got new personnel that we're working with WAST now, and I've met with them, and we're keen to keep engaging with WAST, because as you do, we also have concerns, particularly about the red calls in Powys at the moment, and have had a number of really quite frightening patient experiences shared with us. So WAST will now become a permanent presenter at our full council meeting and at our local committee meetings, which is a really, really positive move. I think finally, really, I just wanted to update you on the Citizens' Voice body. It comes into being in April 2023. There are 7 work streams that have now been working on location, strategies, legislation, governance for the last 6 months, mirrored with Welsh Government work streams, and those are starting to come together. So we anticipate that the recruitment for a chair and a vice chair will start probably about April next year, and the interim board will then be appointed. So lots of training going on for staff, because obviously social care comes into that bag now, and we've predominantly worked with health, but I think that's a really positive move. And when we look at delayed transfers of care and the pressures on the social care element of that, I think that will join that little loop up quite neatly, hopefully. So I think that's all I really wanted to pick up, Chair. I'm happy to take any questions that people might have, and I think that's it for me.
Well, thank you, Katie. That's really helpful. It's always very, very useful and very interesting to read through your reports. Does anyone have any questions? There's a hand up from Robert.
Yeah, thanks for the report. There was just one thing I wanted to check out. You reported there on Swansea Bay's
Yeah, unfortunately, this has happened a few times, and where a change is happening in one health board that impacts or could impact on Powys patients, and I'm afraid the communication between us and Powys Health Board is great, fantastic. But it's not always quite so good between other areas, and so we were alerted to that change, which you're right, Robert, had an impact on Ystrad patients of a particular postcode. We were not involved in that process from the outset, and so we've just commented on that needs to be, considered in the future. It happens. It's happened before. It happened recently with sexual health services in Iron Bevan, and it happened with the closure of practice in Towyn. So if it's cross-border, other health boards don't always consider the impact it might have on other patients, and I know Hayley does her best and Carol to reiterate that, and I do my best with the CHC colleagues, but it doesn't always happen, and it didn't happen on this occasion.
Okay, thank you. Melanie, I think, was next.
Mine is just to make a comment, say thanks to the CHC, the way they worked with the health board while I've been vice chair. I've often come to the meetings, and I think that it's a really good tone that is set between, both parties and how we've managed to go forward. So I just say thank you particularly to yourself and Francis, who I've worked mainly with, and to welcome David, obviously, into that role. But really just to say thank you for the way the officers and the members of the CHC have conducted themselves with myself, and I'm aware of everyone else while I've been vice chair. So thank you. If you could pass that on to the young members, I'd be really very grateful. Thank you.
I will, Mel, and of course wishing you all the very best for the future as well.
Thanks, Mel, for that. And Julie?
I think just a point to raise, as Katie's raised, the establishment of the CVB, just recognising our responsibility as a board, as the current employer for everyone who is employed within the CHC at this moment in time, and the transfer of staff into the new body. So we are obviously minded of our responsibility in that, and we are working closely with Welsh Government colleagues and the board of CHCs as well, to make sure that we can do all we can to work with staff during this change period. As Katie said, there's some significant changes.
Thank you. I'm not sure whether Tony's hand was up at one point. Perhaps not. Okay. Well, I'd like to just before we leave this item, reiterate my congratulations to David on his appointment. So I very much look forward to working with him, and thank you again, Katie. Right, now we can move on to the assurance reports. Really, these are just for information, unless anybody has a particular question about any of them. Ronnie, would you like to introduce this item?
Thanks, Chair. So in terms of the health, so this item brings together, are we taking all three together, Chair? Sorry.
Sorry?
Are we taking 37, 38 and 39 together, or just 37?
37 first, yes.
Thanks. So this paper brings together a summary of activity for the board's committees and our joint committees. Each chair has a report included, and so I don't know whether you want to go through them in detail. Perhaps the exec committee report, as it was circulated slightly late.
Yes, maybe the exec committee was the one that arrived late, unless anyone has already spotted anything in particular from any of these subcommittee reports.
Perhaps I could just help. I can help with this one. So board members will see that many of the items that we discussed through the executive committee have indeed been considered here at the board. So integrated, maternity service report, the issues of board and committee arrangements was at the previous board, of course, committee risk registers, etc., or that they have gone through to another committee, in particular the Patient Experience Quality and Safety Committee.
Yes.
There wasn't anything specific other than those items that have already been through to committees that I feel need to be brought to the board members' attention at this stage, but of course happy to take any questions.
Trish has her hand up.
Actually, it doesn't relate to the executive report, but to the joint committee report.
Okay, thank you.
Right, that's fine. So I don't think anyone does have any questions for the reasons that you've already stated, Carol. Joint committee reports, then. Trish?
Yeah, it's in relation to risk, and just to note that the neonatal transport contract has been extended until I think June 2022, and I just wondered if I could pick up that issue with Carol outside the meeting.
Very happy to pick that up, Trish. Yes, I'm familiar with the neonatal transport work that's underway, being led by Swansea Bay Health Board. Thanks, yeah, happy to do that. Chair, I don't know, I think we moved more swiftly into the partnerships. I'm not sure whether there was anything in any of the other committee reports anyone wanted to raise.
I don't think so, Carol. They had their chance.
Oh, yeah, but no worries. Thank you.
On the Mid Wales Joint Committee, which I chair, just to say that the work of that committee is being thoroughly reviewed at the moment, and we'll hear more probably at our next board meeting. Right, okay. Then the next item, 3.8, partnership arrangements. Carol, you've just helped us with.
Not at all, not at all. Thanks very much, Chair. I wasn't planning to raise anything in particular. Clearly, we've had the first meeting of the new partnerships, Population Health Partnerships and Planning Committee, which will provide a really, I think a really useful committee in which to get into some more of the detail around our partnerships, of which there are many. So I wasn't planning to pick anything up specifically unless anyone wished to raise anything.
Okay, thank you. And then on, I think, Julie, the meeting was cancelled for lack of quoracy, the board's local partnership forum. Is that right?
Yes, the last meeting was postponed and rearranged.
Okay, thank you. Was there any other urgent business for today? No? So in that case, we close this meeting